and the stage is yours. Thank you.
Yeah, thank you so much. Is that working? It's okay? Yeah, great. Thank you so much for the kind introductory words. Stefan, thank you, and all the organizers in the Tom Walig Stiftung for having me here today and giving me the chance to talk about what I think is my hobby that became my profession. And it is a fantastic, I think, opportunity to exchange with the field here. I've been listening yesterday and I learned a lot about HSP, and I think there are indeed a couple of overlaps. And I might try today to give you just a few thoughts that I have, being a clinical trialist, being heavily involved in the Huntington community for now, well, I don't tell you how long, but you'll see in a few slides. It's been a couple of years. So there are challenges, there are opportunities to better therapies, and I think our two fields actually pretty much have similar problems, and maybe I can relate to this today. So yes, I have a couple of conflicts. I have lots of involvements in international communities. I lead a lot of clinical trials, including, if I have the time to talk about this at the end today, the current gene therapy trials of Unicure since about 10 years, which is an amazing experiment for the Huntington field, but also challenging in certain dimensions. So just to declare that I actually ended up with bad luck in Huntington's disease. I told a couple of people yesterday, back in 1990, I was looking for a PhD at the University of Münster and actually wanted to work on epilepsy. And I found a place of a PhD project for me and my two friends. We wanted to do it together, and my friends, however, were fraternity people. I wasn't. They took me to a beer garden, and I had to drink beer, and then we had to draw lots, and I took the smallest match. So I ended up in Huntington's disease not as a choice, right? I was given Huntington's disease, and I was actually pretty frustrated back then because I thought, how are you ever going to do a study, a PhD, even in Huntington's disease? And I'm so happy today. Sometimes bad luck is good things. So in 1993, actually during my PhD, the Huntington gene was found. And to be honest with you, I put the slide in because yesterday your father said that he's still waiting for the therapy. And in 1993, as a young medical student still, I was so optimistic, having already had 3 years of experience, 4 years of experience with Huntington patients. I thought, okay, great. Huntington's is a bit of like a small field, but you get into that, you solve the problem, and then you do something else, right? So here I am, 30 years later, right? So we still don't have a therapy, but we're working on it. I think a lot of the things that we had to learn the hard way, you can probably learn from us in a way, and we can exchange on how to move better. So luckily, and that was the big thing back then, Huntington's disease is autosomal dominant disease. I learned yesterday, obviously, that a lot of conditions in HSP aren't. It does make it easier to think about therapies, particularly if you look at this particular way of the mutation, because it's a CAG repeat expansion, as many of you know, and luckily the phenotype is pretty much governed by the CAG repeat. So we have a reduced penetrance, but I'm not going to get into that too much. You know that once you have a certain CAG repeat, you get Huntington's disease. Now, this CAG repeat translates into a polyglutamine chain in the huntingtin protein. Well, that's a possible avenue for therapy. We'll visit this later. But actually, I think one of the big caveats that I want to make right away here is that the whole field in Huntington's disease has been looking at toxic function of the huntingtin protein. And what we learned recently, as many of you may be aware of, we have somatic expansion. And somatic expansion may be the much better explaining mechanism of the disease, to be honest. I was always pretty nervous giving talks, I have to admit, and back then I was at a stage at the World Congress 2009 in Vancouver, and I gave a speech about Huntington's disease assessment tools, and I said to these people, look, there is one thing that I just don't understand. I was a young resident. If you have 2 mutations of the Huntington gene, why don't you get a more severe disease? And there are people that have 2 mutations. We even have some in our collective. So if you have twice the gene, you had 2 parents that had the Huntington gene, and you had, let's say, 45 repeats and 44, why are you not more sick than the person that only has 45 if this is a toxic gain-of-function mutation? Just keep it in the back of your mind. And I think a lot of the questions were never really properly answered, and the thing that I want to tell you is be open. Be open to new ideas. They may shift your whole field, and be transparent. Nevertheless, let's put the somatic expansion a bit at the side at the moment. We might revisit it at the very end. It is a therapeutic target in Huntington's disease right now, and how we got there, I'll tell you. So luckily, the CAG repeat, nevertheless, governs a lot of the disease. So it governs the age of onset as depicted on the left here. It also governs the progression of the disease as we have more recently learned, which means the longer the CAG repeat, the faster Huntington's disease progresses. That's true for the clinics. Depicted in the middle, that's the clinical score, but also for the imaging. That's actually very useful if you want to develop disease trait markers for clinical trials. That's my big passion, as you will learn in a few minutes. Nevertheless, as I said, 1993, I was up in the mountains climbing, dreaming about therapies for Huntington's disease. This is still the story today. So we do have, on the left hand, we see a 60-year-old brain of a non-Huntington patient, and on the right side, you see a Huntington brain. You see there is vast degeneration in these brains. And we can see that, how this evolves in big biomarker studies that we do. We've been looking at when these changes evolve, and actually when I move the mouse here, can you see that on the screen? Good, great. So on the left-hand side here, what you see is a panel of voxel-based morphometry. That's a way how to quantify brain areas. And this is a population of 60 gene carriers with Huntington's disease, 10 to 20 years before the onset of the disease. This is 0 to 10 years. This is stage 1, stage 2 Huntington's disease. There was this big TRACK-HD study that we did many years ago. So there were changes detectable 2 decades prior to onset of the disease. They decline over time. One thing that I want to alert you to if you want to do a clinical trial, and that's not trivial, the green curve here is actually the controls. So our brains shrink as well. Don't forget that if you want to look at the delta of a treatment effect on imaging. So we have to have really good data in order to be able to power a trial for looking at imaging, and there are a couple other problems associated with this that I will get into later maybe. Here on the right, you see a video of a pre-manifest gene carrier in this TRACK-HD study, and you see how the striatum is melting away. So, as I said earlier, I think the natural thing to believe is the bad guy is the Huntingtin protein, the extended protein. There are aggregates that form, and we've seen aggregates in multiple neurological diseases, and we aren't always sure how significant they are in terms of the pathology. We can measure the Huntingtin, meanwhile, pretty well. We actually have resolved the structure. Colleagues in Ulm were very much involved in that in Germany, and we do know that the polyglutamine changes somehow the configuration of the protein, obviously, as we discussed earlier, may have, that's what we all think, may contribute to some toxic function of the Huntingtin. Importantly to acknowledge, Huntingtin interacts a lot in the metabolism. So it's not a protein that's just somewhere there and does one or two things. It has a huge interactome, and that makes it more complicated, because if you think about therapies, yes, the clear thing, and that's what we're trying in the Huntington community right now, is to reduce the mutated Huntingtin, but depending on what mechanism you use, you may also reduce the healthy Huntingtin. Keep in mind, if you reduce the Huntingtin in animal models, a knockout is fatal early on, and if we do it later on, it results in severe deficits. So the function of the protein is important, obviously, and there are lots and lots of functions. How does Huntington's disease look like? A brief introduction for those who aren't in the clinic. Because of the neurodegeneration that I also already showed you, I think it was quite impressive how many areas of the brain were affected. We are not so surprised that we have a very complex phenotype. It's motor, psychiatric, people get behavioral problems, they can be anxious, they can be a little difficult for their partners. There's cognitive decline eventually in the disease, and all of this, in the end of the day, contributes to reduced function. A typical Huntington patient would look like that. You see involuntary movements pretty much everywhere in the body. It's a ubiquitous disease, meaning that we have signs everywhere in the body. Typically, these involuntary, as we call them, choreatic for Korean, Greek, the dance movements. In that stage, for instance, the patient was cognitively very capable. This is a very typical walk. If you see the patients, you sometimes want to kind of jump next to them and help them. You don't need to. The cerebellum actually is still pretty well preserved, so they usually don't fall. But that's a very typical Huntington presentation. If people have more advanced disease, they sometimes get more chorea, they get a bit hectic, as you can see here, and also that's the stage when usually cognitive impairment kicks in. and gets more and more problematic. In late stages of the disease, people become catatonic, really, and dystonic, lots of dystonia. And at that stage, this person wouldn't be able to speak anymore, and sometimes not able to even swallow, and they usually die of pneumonia. We have one very dreadful form of the disease, which luckily we don't see too often. It's the juvenile or pediatric form of Huntington's disease, with very long CAG repeats. You see this is a 20-year-old young woman, and she has had the disease with age 15. And we've seen these patients in Ulm at our colleague Bernhard Landwehrmeyer's place. And you see it's not so choreatic. There are not so many involuntary movements. It's more dystonic, actually, as a phenotype. But these patients exist as well, and we shouldn't forget them, by the way, when we do clinical trials. One of the big take-home messages I think that I can just give you from our field, and I've thoroughly enjoyed working in the Huntington field, is the big collaborative effort that we are making. And I realize you do the same here. I think it is important in rare diseases to work together. You see a picture here of Nancy Waxler, actually back then in the Venezuela project in the Lake Maracaibo district, where due to certain cultural habits, their promiscuity is something which is very normal in these societies. We had very, very many Huntington gene carriers. Also, as I mentioned earlier, double gene carriers. So this was kind of a living laboratory for Nancy. I know her very well because I worked at Columbia University and she was teaching there. Her family was essential, actually, back in the 60s to form the Committee to Combat Huntington's Disease. That was the cradle of the later Huntington Study Group, and today our European Huntington's Disease Network. So working together, working in networks is essential. Without that, we wouldn't have found the gene, we wouldn't be where we are right now. So what do we do? Actually, we have the privilege, we discussed that with a couple of people yesterday. We have a big donor in the Huntington field, a person that is involved with Huntington's disease with their family. They donated the incredible sum of $2.3 billion to the Huntington field, to a foundation called CHDI, that stands for Cure Huntington's Disease Initiative Foundation. And we have a huge study, a huge project called Enroll HD, and I can only invite every field of a rare disease to put up a similar network. It's obviously, you don't need that much money. The money is for something else. They have hired 150 scientists. The network itself isn't that expensive, and you can put up web pages where here we can introduce and monitor manifest Huntington gene carriers, pre-manifest gene carriers, at-risk people, even controls. These networks have been extremely powerful. We can recruit into clinical trials, we can do observational studies, and I'm very proud to say that Europe actually is a very, very essential part of that. Some people over there might not like to hear that much anymore, but Europe contributes 2/3 to this cohorts, actually basically also to all big clinical trials, maybe because of that. We also have a large pre-manifest group that is growing because the foundation and the field steers a little bit to go to early interventions in studies because there is still more preserved neuronal function, and there are a number of reasons to consider that, but very powerful tool. Add on to Enroll HD, we were able to do a project called HD Clarity, which is extremely helpful. I'm in the committee that gives access to those samples if people request samples, and I know what's coming. We've had a couple years now to collect CSF samples on top of Enroll HD visits. Those people that volunteer for a CSF collection can add to this biobank, which is extremely helpful. Whenever there is a new idea of a new target, let's say right now, somatic expansion, people try to push targets, they can go back to the library and request hundreds of samples of sometimes 3, 4, 5 years follow-up. And what a difference, right? In the past, we had to say, okay, we have this idea, now we have to ask people, we have to go to ethics, and until we could do experiments, it took years, that's over. And we're very proud at GHI, together with UCL, to be the big contributors to this study. I think it's a very important project, and it helps to develop target involvement markers for therapies. Now, we have been able, with HD Clarity samples and a number of other samples, to develop pretty good assays for mutated Huntington. I'm not going to go into the details here with that, but I want to put some caveats out. So MHTT, even wild-type Huntington, though I don't get into the details, it's much more complicated actually, but the mutated Huntington we can measure. And that's great. It's fantastic in phase 1, phase 2 clinical trials. It is a bit difficult to get persistent data on that. If you go multi-center, if you're honest with yourself, and I can tell you, you have to be honest, like if a small trial like our gene therapy trial, I look at all the patients, I look at the data, and there is a lot of variability in these assays still. So I think there is things that we need to improve. Another point, a big caveat, it is great for making us believe or making us know maybe even that we hit the target, but regulators won't accept it as an endpoint. At least that's what we have been told. So mHTT is not a regulatory approval endpoint. By the way, you might think about that. If we do an ASO therapy in the spinal cord, mHTT changes in a very different way than if we do a gene therapy back in the deep brain structures, because the communication of the mHTT to the CSF is very different. So we shouldn't be too certain that these measures that we usually have in animal models very often do behave the same way if we use them in humans. They are also a risk. We have to know exactly what we are doing before we put them, let's say, a primary endpoint. Same, we discussed that yesterday with NFL. NFL is extremely helpful. It's a damage marker of acute damage. We use it in DSMBs, for instance, in the gene therapy studies. We do look at it. I certainly think it's very important information. The feedback, however, that we get, and we can measure it in CSF, we can measure it in plasma and blood, but regulatory agencies tell you, okay, that's great, put it as a secondary, as a whatever, exploratory, but we will not approve a drug based on that. At least in the Huntington field, that's the feedback that we got. So there are some challenges with this, but you can definitely use these markers for early trials to inform yourself, and I, of course, encourage everyone to develop measures that are actually target involvement markers for certain therapies. That's important. But again, for regulators, that's a different story. And beyond that, I'll keep that very short here today, also imaging. I mean, we've been investing a lot of time, a lot of money from the foundation in qualifying imaging as an endpoint. In the end of the day, there is a CPAS consortium on Huntington's disease research, where regulators are involved, and the clear message last year was imaging is great, it's fantastic, but it's not going to be a primary endpoint, at least for now. And that's the feedback that we also got from regulators talking to about clinical trial design. So you can use imaging to convince yourself that you're in the right way. You can use it as a secondary, maybe a third measure, but it's not going to be the primary that brings you to the target to get a drug approved, at least in Huntington's disease. So that's actually, and this is an old story that I've been working on for many years, but I have to share this with you because I think it may be helpful for you as well. It's a research field that we've been investing in a lot to say, what else could we use? What would be possible to use in a clinical trial to give us evidence to see that the treatment works? What can we do to reduce the sample size of trials, to make early decisions possible, and to convey also a message to regulators that certain therapies would get to the market in the end of the day, because that's what we want. So I want to share some experiences. They may be a bit biased. I'm clearly a guy developing these kind of measures. I'm talking about quantitative measures, about objective measures, and we discussed that yesterday. The talk from Paris included some Q-motor data. So Q-motor stands for quantitative motor assessment. So what do we want to do? In the end of the day, we want to make the development of drugs in the process from early stage development to in the end of the day, pivotal trials more reliable and more meaningful and reproducible. Sorry. I feel actually very privileged that I can talk here today, because 3 days ago I wasn't sure. I came back from the United States from a conference, and as you know, there is always a lot of air conditioning, and I caught my voice wasn't working well. So anyway, here we go. So we want to increase your capacity to have an early look at whether treatment engagement is working or not. So the idea is to convert from clinical rating scale that was discussed yesterday already to a quantitative objective measure. To be honest with you, the idea to me came when I talked to my former chairman, who was a vascular neurologist, and as a young neurologist, I was quite impressed going to the emergency ward and having ultrasound for quantifying stenosis of the vessels. So that was nice. In the hand of a neurologist, I didn't need a radiologist. I hope there are new radiologists in the room, but we could pretty much make our diagnosis ourselves. And back then, I had some background in studying a little bit physics. I'm a ham operator, radio amateur operator as a young guy. So I know how to do stuff with technical things. And I said, that can't be. It was back in 1996, 97. It can't be that everybody has objective devices and we are just using scales. It's old-fashioned. We need something computerized. So the idea came to look into the opportunity whether we could actually convert the clinical rating scales to something more objective, and we started doing experiments, and I'm not going to get into the details. I will summarize what we found out. We have come up with a system that uses sensors, force sensors and position sensors to phenotype and characterize the severity of the motor phenotype of patients, particularly in Huntington's disease. These systems have all been used actually in military applications or in the car industry. We were so lucky, looking back now, that when I got a grant to do that, a DFG grant from the German Research Foundation to work on that at Columbia University back in the end of the 90s, that we selected these tools. We looked at a lot of different sensors. We selected those. They're quite expensive. Every system costs as much as a small car, but nevertheless, the big thing is they are extremely high QC'd and they are very robust. If you drop them, nothing happens. So a lot of tools we develop these days, take that in the back of your head if you do develop tools, they are very fragile. So give you the example of the gene therapy trial. We are doing patients in 7 years. You need a system that works for 10, 15 years. So you need something robust. We learned that the hard way. So we use pre-calibrated sensors, force sensors, position sensors, to basically transfer the total motor score to a quantitative measure. And I'm going to show you a couple of results of that and how we do that, because it does reduce inter-rater variability and it gives you access to small trials. So instead of doing that in the UHDRS, and you see this is a Huntington patient, grade 1, a little slower, maybe a little irregular, we do this, we transfer the tapping on a sensor and we get a physiological signal out of it. This would be grade 2, a bit more severe in Huntington's disease, grade 2, maybe even grade 3. It's very difficult, though, in a clinical rating scale to really standardize that. So we have been doing that in the Huntington field for years. We've been coming up with video certifications, with trying to teach people how to rate the videos, and in spite of that, we still get a lot of error. So this is how we do this in the objective field. We use a force sensor. The patient gets a beep, taps on the sensor, and we get these signals here that we extract. For instance, the inter-onset interval between two different peaks that the force curve generates. We have a number of tests. We can do tongue motor, grip force control, pronation, supination, finger tapping, foot tapping. Foot tapping is probably the most interesting for you guys here, and I'll share some data about that later. So what we get in the end of the day is an objective measure, a curve, a gestalt, let's say, like an EEG. I'm a neurophysiologist, so I like that. It's objective, you can look at it, you can see what's wrong. If you have some experience, you can actually read it like an EEG, right, in the clinic. And we extract, let's say, the inter-onset interval. There's the inter-peak interval, the inter-tap interval, a number of defined intervals. It's very simple. You see here, this is normal, this is quick, this is irregular, more irregular, it's visible. Regulators actually like that, because it's not like a black box, right? So we tested these assessments in the big TRACK-HD biomarker study that we did in Huntington's disease. 120 controls, 120 symptomatic, 120 pre-manifest. We did that and published it well in multiple journals. And the thing that I want to highlight is that if you look at this tapping, this is the control group of TRACK. In the cross-sectional data, this is the people 10 to 20 years before onset. 10 to 20 years before onset, and this was highly significant. It's multiple measures. This is 0 to 10, stage 1, stage 2. You see signals very early on. So Huntington's disease clearly isn't like stroke, where something comes from today to tomorrow. It evolves over time. Why did I get into that? Because my dream back in 1993 was to do preventive trials. I want to do a trial before the damage happens. And here we go. We wanted to evolve. We wanted to develop measures that could actually be used to do clinical trials in these populations. And we found they correlate to clinical scales, to the genetics, to imaging. It's always important to also look longitudinal. So this is the 3-year data of TRACK-HD. You see the green curve here is the controls. The blue, the light blue, is the people 10 to 20 years before onset. That's a slope. That's 0 to 10, stage 1, stage 2. I'm not going to get into the details, but in the end of the day, we have a measure that allows us to do clinical assessment of the phenotype of Huntington's disease, even pre-manifest. The strategy with regulators right now is that if we get a signal in the early stage symptomatic people, we might be going back to prodromal pre-manifest and use these measures where obviously rating scales wouldn't work. It's not a biomarker, it's not a surrogate marker. Regulators clearly said This is a clinical measure, and that's it. So we are lucky in that sense. And I think we clearly could show the connection between the function and structure. And I'll give you a couple of examples now where this could be seen, what we actually learned from using these measures. So clearly what we see is that alongside the imaging, the Q motor changes very, very early on in the prodromal phase. And until function drops, there is a lot of time. And the question really is, can we use that somehow? That was my major research interest. But when we published that data or showed that on conferences, people came along and said, there was a guy, Balthazar Gomez-Mancilla from Novartis, and he said, well, Ralph, why don't we use Q motor in a clinical trial? So they had this compound AFQ-056 that they had under development for dyskinesias and Parkinson's disease, and they wanted to use it in Huntington's as well. So we did a 1-month trial. Each of the groups that I'm showing you here is just 20 people. It was a phase 1 trial, and I want to highlight something here. The clinical scale and the finger tapping in that trial, 1-month trial, again, we started the dose here, showed a placebo effect in the dotted line, the placebo group, and a treatment effect, but there was no separation between the two groups. What we learned for the first time in this trial was that if you look down here, and the graph hasn't been done very greatly, but you see the low variability, this is Q motor finger tapping. There is no placebo effect. This is the left hand, the right hand, by the way. They happen to be the non-dominant dominant in all of these people. So you see there is no placebo response. There's a treatment effect that's even significant, and when we stop the dose, then it goes away again. That was the first time in a clinical trial that we saw that. We didn't expect that. We didn't have a placebo response. Oh, what does that tell us? So there was another test, I talked about the lifting trial that we did, where we have the same sensors that we use, and we have the people lift the device after a beep, and we measure the grip force, and we measure the chorea, the involuntary movement. So if the patient has a movement, we measure XYZ, roll, pitch, yaw, that's the orientation. If they have a movement in whatever direction, we take the derivatives and sum them up, and we get like bumps. So the more bumpy this is here, the more amplitudes you see, the more chorea they have. So we can quantify the chorea. I told you earlier, Novartis wanted to use this drug to reduce chorea. So what we found out clearly is in the rating scale, chorea rating scale, there was again a placebo response, but no treatment effect. Okay. In the Q motor, there was nothing. There was a straight line. I remind you, these are 20 people per group. So we just thought, okay, that's interesting. We see no placebo response. So we did have a proof of concept, if you wish, for a central signal because of the finger tapping signal, but we found signals in very small groups and we didn't see a placebo response. Same thing was Ipsen, phase 1 study. It was also a drug that they wanted to test for reducing chorea. It was a 1-month study. We did multiple assessments, and what I want to highlight here briefly is that we had an 11-point improvement in the rating scale of the people that rated, but on the Q motor over that month, we had a very stable signal. Very stable, no placebo response, and there were actually treatment responses, and this time it was the inter-onset interval of the tapping that was even significant. There was a worsening in the phenotype. We saw the same in another tapping variable. You see always the blue line is the controls, and we saw it also in the chorea. The chorea actually got worse. That wasn't significant, but if you appreciate all the signals going up here, so there is always worsening. In the end of the day, we stopped this trial because they also had other side effects. I just want to share this with you. No placebo response, n equals 5 here. Placebo group to treatment group, n equals 5. So what does that mean for other studies? Would it be helpful to use such measures in other settings? Definitely, I think we see that this is pretty sensitive to use these quantitative measurements. And I'm going to share, lastly, a couple of objective data from large trials. We did a phase 2 study with Pfizer. Those were about 50 sites, 300 patients. And again, we got a huge placebo effect on the rating scale. We did see that the placebo group in this trial on Q motor progressed. This is the randomized trial. And we had a dose-dependent treatment effect in those people taking the drug. Okay, that was interesting, a dose-dependent treatment effect, but what was maybe even more interesting, and I want to highlight here, is that in the open-label study on the right-hand side, we pushed those people that were on placebo before. We have the baseline is taken here, and then we put them on 20 milligrams, and what you see is that those people that previously were on placebo now get the drug, and the effect that we measure on Q motor is exactly the same that we initially had. So we reproduce in open label what we found earlier. If you don't have a placebo effect, maybe you can measure against the baseline. Second last example is the Legato trial. Maybe interesting for your field as well. I saw in the program somebody is going to talk about, I think, fingolimod later on. So we tried to reduce the inflammatory responses in Huntington's disease and explore what that means. Laquinimod was a drug under development for MS by Teva. Short story, 1-year trial, 400 patients, 50 sites. What we found, again, TMS, total motor score, placebo effect, no clear signal. Imaging, however, was preserved. We had less degeneration in the treated people, and alongside we had a Q motor signal. So this wasn't standalone. The imaging was accompanied by, again, a placebo group that didn't show any signals, but the treatment groups showed a certain improvement, meaning imaging and the quantitative measure showed a signal. Now, you could ask, why didn't we follow up on all these things? Honestly, it's incredible, but Novartis closed its neuroscience department, Pfizer closed its neuroscience department, and Teva bought a huge company and overburdened itself and also closed research. That's the truth. So 3 companies left neuroscience. A last thought to share on that is for those of you who are clinical trialists. Before the database lock in Legato, I told my team, please pool, remember we had placebo and 2 dose groups. Please pool those people that did the best over the year, because we had 3 treatment groups. I said, we're blinded, we don't know what they do. Pool them, the best, the worst, the middle. Plot them. So this is the worst, they progress. We've learned all the trials, there's progression of Huntington's disease, there's no placebo response. If that's true, if you look blinded at these measures, you can see there's a treatment effect. For those of you who are clinical trialists, they will appreciate what that means. You could theoretically use such leads in a blinded way to inform adaptive clinical trial design. That's my hypothesis, but that's what this shows. Last example, we used it in a huge development with predopidin. This was published also in the Lancet Neurology some time ago. Again, clinical rating scale shows big placebo effects. We have no placebo effect on the measures. The finger tapping, we see dose-dependent benefits, and they actually are particularly pronounced in 45 BID. We have reproduced this in another study that was just published in Nature Medicine. However, in a subgroup of patients that didn't take neuroleptics have a dirty effect on that. So you see again, Q motor shows a clear signal here in multiple domains, actually, again, no placebo effect. And this is this time corroborated with a cUHDRS clinical signal, and we'll do a phase 3 trial starting very soon to assess that and see if that drug could bring some motor benefit to patients, maybe even some disease-modulating effects. I want to more talk about the clinical trial technology here because that may be helpful for you than the facts themselves. So I think objective tools can be helpful also in large clinical trials. We don't see placebo effects. We actually see a very good reproducibility across trials. If you look at the Q motor measures versus clinical scales and look at different studies, each of these curves is a different study. They behave very much the same. That's true for the TFC, the cUHDRS, or the total functional capacity, all important scales in Huntington's disease. These measures at baseline have similar characteristics, and regulators really like that. Last point, we can actually predict the benefit later on in the cUHDRS, a classical clinical scale, if we have early data on Q motor. That's going to be very helpful for prodromal trials. So we have correlation with clinical endpoints. That's important if you want to validate a measure, and we can use it. We also have pronation supination tapping. We also have foot tapping, which may be important for you. We also have a cognitive quantitative test meanwhile, for instance, the FDA-approved trail making test, also that can be used to quantify things. We do that across the world. We currently equip 2 big trials of 60 and 20 sites, and this is how the devices are being shipped in Münster, and you're welcome to visit us and look at it. We've done multiple collaborations, and Q motor again, now it's under review by regulatory agencies as well. We've done, for instance, a study on Alzheimer's disease. There is a motor phenotype on Alzheimer's as well. And we have done a very fruitful collaboration with the team in Tübingen, with Mathis and Andreas Tarschitz. We actually developed some new tools. We can also assess tools like spiral drawing or reaching for phenotyping ataxia patients. which we did in this context. We have also shown progression in ataxia. And the last thing to mention is that we have also done, besides treatment involvement that we can show in ataxia, it's important always to also see whether your measure can actually measure treatment effects. We've also piloted this in HSP. So I think HSP, that's again the group of Andreas Traschütz and Matis Sinovcik with Rebecca Schüle. We show also that the phenotype in HSP can be looked at. So switching gears, we have done a number of assessments also of other technologies. There are big EU projects that look at sensors. It's a 44 million euro grant that we do since a couple of years. We just learn how these assessments can be used. It's always important to get your clinical experience whether certain devices can actually be used in the clinical context, and sometimes that's the hard way. I am very much for a data-driven approach in whatever you do, so I think objective and quantitative data is hopefully helpful. We do our own study. I mentioned that yesterday to some people called Focus HD, which is a new biomarker study. It uses the backbone, the electronic ECRF, that I think you use in the ataxia field as well, and that we use in Enroll. Okay, stop with that, switch gears. The last few minutes I have, I would like to talk about therapies in Huntington's disease, because that's really where the juice is, and that's where we want to make advances. We have, luckily, been able, because of the monogenetic course of the disease, which obviously is different to what you are facing, but I heard and learned that you have a number of mutations that are quite frequent. As I mentioned earlier, the big target, of course, is to try to reduce huntingtin, right? Because we think there is a toxic function. That's the first thing the field really embarked on large scale. Reduce huntingtin and see if that has a clinical benefit. We obviously have two copies. We have the healthy, we have the mutated copy. And the early big news that we shared in the community was the Roche tominersen ASO that was able to lower huntingtin in a phase 1 study in a dose-dependent way that looked pretty good. Hard learning experience was that the whole field actually thought, oh wow, that's the solution. And we jumped, and I think caveat, don't do that in your field. We jumped from a phase 1 straight to a phase 3. Everybody thought the problem was solved. It wasn't. The study had to be discontinued. We learned that actually patients got worse. So this is the control group here on a clinical measure, 2 clinical measures, and you see there is even a kind of a dose-dependent benefit, worsening. So people that were treated with tominersen got worse. Protein lowering worsened the disease. We don't know. I personally don't really know, and nobody knows in the end of the day whether it was the protein lowering. I think it was probably a toxic effect of tominersen because we saw some inflammatory reactions in the CSF, but clearly we saw a dose-dependent widening of the ventricular spaces, which I forced the authors to declare in a letter to the New England Journal of Medicine because they had kind of hidden that in their data, and the study was discontinued. But there are other approaches as well that go for allele-specific lowering. So there's a very interesting program since many years by a company called Wave, which is targeting SNPs close to the mutation. That could be interesting for you as well, of course, and I think it was discussed. So we first of all looked at feasibility. We had enough people carrying the SNP. You always have to have the SNP at the mutation site. So you have to genetically test all the patients. We did first 2 SNPs, SNP1, SNP2 targets, and honestly, we saw a little bit of lowering of huntingtin, but this is the mutated, this is the wild type assay, which you see the variability here. It's huge variability. But there was a trend, but this didn't really work out well. So we stopped these 2 trials, but similarly to the CAR development, we have a development in ASOs. So we have more modern ASOs these days, and the new backbones are much better tolerated. They're much better penetrating to the brain. So we did preclinical experiments that clearly showed a dose-dependent lowering of RNA and also protein in the target areas, and we did a huge study called Select HD, multi-site across the globe, and the data has just been released. So indeed, we do see in the single-dose phase 1/2 study here, we do see an allele-specific lowering of the mutated huntingtin, and in the multi-dose therapy, we do see a maintenance of that lowering effect. So that is very interesting. For the first time here, we've seen an allele-specific lowering in patients in a phase 1/2A study, and we are planning a phase 3 study currently. So nevertheless, the problem here is similarly to what I earlier said was the two mutations. The field is ignoring that. How do the ASOs actually spread if we put them in the lumbar space? I have my problems with this. So the last thing I want to mention is that for about 11 years, I'm now working with a company called Unicure on the first gene therapy for Huntington's disease. So they introduce, instead of repetitively having to inject ASOs, we put a cassette in, a virus that carries DNA information, and in the end of the day also gets RNA, the messenger RNA, degraded that is for Huntington, but it's not allele specific. It lowers the mutant and the non-mutant form, and we put that in surgical operations into the brain bilaterally. There is a video of it here. It uses gadolinium. We've tested that in mini pigs. It works well. It's safe. It's reducing Huntington levels, and we've done a huge study, which was a bit sham controlled in the United States, and a similar study in Europe, a phase 1-2 trial, and it's a very complicated procedure to plan. The operation is a big committee involved. The surgery takes 14 hours per patient, so that gives you a little bit of a limiting factor as well in terms of using it. But recently, the company revealed some of the data that they have at year 3. Big caveats, this is only 12 people. This is the CUHDRS, a clinical scale in the patients, and that's a historic control group. So this is the CUHDRS development in propensity score matched people in Enroll HD, and it suggests a benefit. Well, I'm just briefly mentioning that there were some people that claimed Huntington's disease successfully treated for the first time. Clearly, I talked to some people about it yesterday. That's not right. I'm the leader of the steering committee, and we all were shocked when we heard that. It's not true. It's very encouraging. It was a phase 1, phase 2 trial. It sends the right message. There seems to be something, but we have to do a properly controlled trial in order to address the efficacy, and the FDA rightly so pointed that out. So the stock market price here, when they first said they had a therapy, was skyrocketing. Then the FDA gave some first statement, a second statement a couple of days ago. That's not what we want, and I think it's also not good to mislead investors, because we want people to invest in Huntington's disease. It was a very unfortunate way how this was communicated, clearly very disturbing to patients, and I hope if you do clinical trials that you manage that well. Q-motor data is still in analysis for this, and we will see if that reveals something. We do some oral reducing in these patients as well. There was a study that we stopped because it didn't show efficacy, but there's a very promising candidate right now. It's a splicing modulator that has shown some clinical efficacy by PTC. That's going into a phase 3 trial now. Last thing to mention, we have the huge data sets from Enroll HD that allow us to identify actually targets for therapy as well, with those people progressing very fast or slow. And somatic expansion, as I mentioned earlier, is clearly on the target right now. So there's the first therapy coming into phase 2-3 right now, which actually also targets somatic expansion. There are a couple of other companies that I won't mention here today because of the time that have similar approaches. I am very hopeful, similarly to your father, that I might still experience the therapy. I don't know where we will go. We don't know. It's up in the blue, but clearly we have some I think, good guidance, and I think we'll have a cocktail one day that we'll need in Huntington's disease. Thank you. Sorry, it was a lot, but I wanted to share some ideas where we are, and I would also like to encourage you to go your way and to try things in HSP. I think you have the genetics, you have the cohorts, work together, and I think you can go to the regulators then as well, hopefully sometimes. Thank you for your attention.
Thank you, Ralph, for this impressive talk. We will take questions before the coffee break, but for the next speaker, for Fanny Moschel, we have to take questions after her talk, because she will leave beautiful Recklinghausen to go to beautiful Paris. So I would like to introduce Fanny Moschel. She is a professor of genetics at the Sorbonne University in Paris. We know each other since 20 years. And I know you have very nice data to present, and you have always very energetic talks. And the stage is yours.
Thank you very much, Stefan, for the very kind introduction. Thank you, Christelle and Stefan, for the invitation. Thank you, Tom and Suzanne, for always organizing great conferences. I've been to already a couple, so So it was great to see how the field evolves. So today I'm going to talk to you about this drug, leriglitazone, in X-linked adrenoleukodystrophy. And of course, I'm going to focus at the beginning especially on the spastic form of that disease, which is still the most common, which is the adrenomyeloneuropathy, so to speak. So these are my disclosures, especially from the company who produced the drug. And I just wanted to give you, again, a little bit of background of what we are talking about. So this is an X-linked disorders. I'm not going to talk about women, although we do things with women who can be symptomatic, especially with spasticity. But in men, because this is where we so far tried that drug, 80% of patients will develop adrenal insufficiency, so it's not just a neurological disease. Then in all of them, there is this myeloneuropathy, but when I say all of them, sometimes we see patients in their 60s with very mild proprioceptive deficit, usually more between their 20 and 40 years of age, but it can be still very variable. This is something that I would like every physician to remember, and if it's known or not known, this is one of the key messages, that this active demyelination called the cerebral form of the disease, which is something that comes in addition, actually occurs probably in more than half of adult patients. We thought that it was only in the children at the beginning. Now we know it's actually extremely common in adults. So it needs monitoring. And the monitoring is with brain MRI, and I will just comment on that later. We have a treatment for that cerebral form, not for the adrenomyeloneuropathy, which is the bone marrow transplant. So this is kind of awkward. Why would you replace the immune system in a neurological disease, right? And so just to give you a little bit of summary of where we are in the understanding of that is that, as you know, the brain is not just made of neurons, astrocytes, and oligos who produce the myelin, but also of those immune cells called the microglia. And so microglia actually comes from the bone marrow. So macrophage and microglia are represented like these small cells here. And they come in different status. So either inflammatory status, where you need to do when there is some aggression, some kind of repairing. And then you have the regenerative phase, and they're the same cells who are doing this switch. And the switch from one to the other is actually driven by some metabolic factors, and in particularly the beta oxidation. So this has been worked on in Vienna by the group, in particularly of Bergner, to show that ABCD1 has a key role in that shift. And so if you have mutation in there, you are prone to have more of a pro-inflammatory, which is probably also very important for the myelopathy form of the disease. So when we replace the immune system, basically with the bone marrow, you stop this inflammation in the brain. You don't cure the AMN, unfortunately, the myelopathy, but at least you can stop this advancement of cerebral lesions that are life-threatening. The compound I'm going to talk about today, leriglitazone, actually came from the initial work from Aurora Pujol in Barcelona, where she actually discovered in mouse models that there was a whole mitochondrial phenotype to this basically mice, but also that was driven by something called PGC1 alpha, and therefore gave the idea to use a drug that is going to target PGC1 depletion in these mice. And so the pioglitazone was actually very effective in correcting these abnormalities and helping the mouse. So of course we know there are many things that work in mice that don't work in patients. But in this case, actually, it was very useful because if you remember this little scheme I just showed you, leriglitazone is actually going to have an impact on that pathway of PPAR-gamma, PGC1 alpha, a favorable metabolic, basically, impact. And at the same time, it's going to have also an inhibition of the NF-kappa B pathways, so anti-inflammatory action. And this is not just ideas, actually, it was shown, and we could also see it ourselves in macrophages from patients when we use the drug. So this is actually a good proof of concept. But then the leriglitazone has been developed to have a greater in vivo penetration because pioglitazone has not. And this is the design of the multicentric study I'm showing today, whose PI was Wolfgang Kohler in Leipzig. And so we enrolled 116 patients in the United States and in Europe. It was a 2-to-1 randomization for 2 years, and then there was a 3 years extension. There, an important aspect is that, and of course, and that has caused a lot of problem, is that the primary outcome, which was the 6-minute walk test, was negative. And this is something, as you know, we've been talking in this, being to that meeting before, about what could be outcomes. And the big problem when you design a trial and you pick up the wrong one, this is going to stick to you for years. And we are still discussing today with regulatories, FDA, EMA, about a compound that actually works on some things, but because of that design actually failed so far to get approval. So why was the segmented walk test? It's a very common one. It's like the road to road, as you probably know, for the mouse studies. Was picked because there were data from the Krieger Institute that actually, for patients treated for many years with the Lorenzo's oil, that decreased the very long chain, but doesn't have, unfortunately, I know it's still a little bit debated, but doesn't seem to have a clinical effect. And so these data were used to basically power the study. And unfortunately, at the same time, they were work conducted by Mark and Gilling's group in particularly, that actually showed that body sway, which is all this postural aspect, which is very important in spastic paraparesis in general, is actually much more sensitive to change, except that those data came in 2019, whereas the trial started in 2018. So it was a secondary. We knew it was important, but not the primary, unfortunately, which is a pity because actually that reached significance, and so there was a clear trend between the patients on placebo versus leriglitazone. So that's something to remember. Sometimes you better wait a couple of years because in the end, I think we have lost a lot of years since then. There were also other secondary outcomes that actually turned out to be favorable, but only with basically second analysis. So in patients who had less than 10 years of evolution in their disease. So especially the 6-minute walk test actually was positive, but only in patients with less than 10 years. The EDSS and some quality of life also measure, although not significant, but a strong trend. So that's basically the results that was confirmed in the open label phase of the study, that the disease, the leriglitazone slowed the disease progression on the myelopathy, but not to a level that actually is strongly perceived by patients, because the side effect of the drug is in particularly leg edema. And so for patients who actually already have spasticity, and the less you walk, the more edema you have. So there was not a strong perception, and some patients left the study for that. But on the objective measures, it was very interesting. As I mentioned, this disease is not just the spasticity, but this that we see unfortunately too often. This patient was completely well-functioning. He was head of 2 big companies, a very sportive person, a kind of little bit of a strange walk, but that was absolutely not affecting his daily life. And then in just 6 months, he developed this very acute, severe dementia and actually died just a year after disease onset. And so just to say it's again and again, there is no age to develop this cerebral ALD, because in this case, it was completely inaugural. So it's a life-threatening form of the disease. Remember that it is as severe as in children as it is in adults. It's a median survival of 3 years. So it's something to monitor very closely. And how do we monitor? By doing actually brain MRI. So what did we see in this trial? Because we, of course, perform MRI to see if patients were going to develop cerebral ALD. Some patients were enrolled with lesions but arrested, and the majority of patients were enrolled without lesion. So what we saw is that in this 2 years course of the randomization, that pretty much most of the patients who had progression of their lesions and actually who had clinical, really relevant cerebral ALD were in the placebo versus the treated group. And so it's also interesting when we look at the neurofilaments, and we've mentioned that a lot since yesterday. In the leukodystrophies, in particular this one, but also CSF1R leukodystrophy, NFL is very sensitive to change when actually there is inflammation, and so there was this more or less stable levels in the treated group versus a clear increase in the placebo group, and that was highly significant. So when we had this data, that was actually the big surprise. I mean, we were happy with some of the outcomes on the myelopathy, but on the cerebral form, it was very appealing. So based on that, we were able in France to start a compassionate program where we were wondering, can we actually stop the cerebral inflammation in patients who already have that stage of disease, but who cannot be transplanted or are pending to have a transplant. So very briefly, we tried to conduct that even if it was compassionate, in the format of a trial with very regular follow-up. And the same thing we will do in trial, and particularly with cognitive assessment, with motor, with biological and different kind of MRI metrics. And that was published in Brain 2 years ago now. And what we saw in this population of 13 individuals is that we had a very positive response in 10 out of 13. And so the 3 patients that continued to progress were patients that were older than 60 years and also who had prominent cognitive dysfunction at the time. This is the clinical readouts, the EDSS, and there is a dedicated score called the AACS for cerebral ALD. Then we looked at MRI with the score which actually measured the lesion load, which is the low score. And what is of more interest to us, and this is again over the course of 2 years, remember that the median survival is 3 years, is that we saw even a decrease, which is not a decrease of the lesion, but probably of the edema in particularly, in patients who had in this cortical spinal tract involvement, which is the more severe because associated with bulbar dysfunction. And this is the one that this involvement makes us deny transplant because the progression of the disease is too fast. So just to tell you what it looks like, this is actually a patient that came to our clinic after his brother died from the disease because of no follow-up, so very end stage when we met him. And 18 months later, he develops exactly the same lesion than his brother, so especially in the spinal tract and here in the bulbar regions with GAD enhancements. And so when we treat, this is what we see. We have disappearance of the GAD, and then we have even some decrease of that hyper signal, which is probably related again to also benefit on the edema. So unfortunately, because of all the course of, is particularly the failure of the primary outcome, this drug was still not approved. And so now there is a phase 3 study ongoing, which is versus placebo, obviously, the CALI study that started in the United States. And don't get me wrong, I'm all in favor of placebo-controlled trial, but in this particular case, we actually had already evidence from the ADVANCE study. We also had evidence from a children's study that I'm not presenting, the NEXUS study, showing a very important deceleration of lesion of 75%. But still, and this is also to go back to the question about, in this particularly form of the disease, MRI is 100% predictive of outcome. So you should think this is an outcome that regulators will actually take as an important marker, but they don't. So in the phase 2 trial, the outcome is actually survival, which is of course extremely tough. And especially for our teams who have been working for some years with the drug as a compassionate, to now be in the situation of one-to-one randomization is actually very challenging, ethically speaking, I should say. And also, of course, not everything is fair because there is a gene therapy that has been approved in the United States, which is basically doing the same thing as a transplant but using gene replacement. And that drug was approved with no placebo, of course, in children. So it's kind of all relative how it goes sometimes with regulatories. But keep in mind that having your primary right is probably the most important thing. In just a few minutes, I would like to drive you to something else because of what I heard yesterday, although I was stuck with the Dutch band in the train, but I was with you on Zoom, so thank you for that because it worked very nicely, and congratulations to the team who is doing a great job over there. But I wanted to share some thoughts also about imaging development and how we can also move on in that, even if we know that we still need the clinical readouts. Some years ago, an engineer in my team, Isaac Adaniegu, developed this multi-parametric study, both the spine and the brain. I know it was presented yesterday in especially SPG 4, 15, 11. And so we basically conducted this study with not only volumetric, classical volumetric with deep learning algorithm, but also technical magnetization transfer that allow to have a good outcome of gray and white matter in the spine. We also perform spectroscopy, but with help of the center in Minneapolis who have developed a lot of the spectroscopy sequences worldwide, because it's very difficult to do spectroscopy in that area because of the breathing movement, of course. So there was a way to adjust for this motion artifact. And we also perform DTI. We heard a lot about it yesterday, but the major problem of standard DTI, it doesn't allow you to study crossing fibers. So we use this method that at the time was very new, that Isaac developed with the help of colleagues at UCL on pixel-based analysis, which allows you to basically, take rid of this crossing fiber problem and therefore improve your sensitivity detection. And what we showed in the end is that if you compare all of these modalities, which are the one the most sensitive to change, of course, in this context, it was only cross-sectional, so there has been since then some validation longitudinally, and we're also performing the same kind of studies now in women because we definitely need more than clinical readouts in this more slowly progressive form of the disease. And the results in this study was actually that the MTR was the most sensitive to change, but probably because of the very strong spinal component that we have in patients with AMN, which is not necessarily the case in other spastic paralysis. But we also have, of course, very interesting markers for the DTI. But I was very happy with that. I've been doing a lot of multimodal imaging in the past. But the frustration comes when, how can you do this in a clinical context? Because you always need control. You need a control group, or you need a treated and untreated, but what about if we can have something for just this one patient that I want to follow over time? So remember I mentioned this man that was then basically asymptomatic, whereas his brother died from the disease. And so here is just some coronal section where you see some hypersignal of the cortical spinal tract in the internal capsule and some GAD-positive lesions enhancement here. If you see the timeline, we scanned this patient 6 months apart. And in the guidelines that we published with Mar Engelem, it's a yearly scanning. So why did we do a 6-month thing? Well, because of this DTI maps that I'm showing you, where you see that there is a clear worsening. You don't see this kind of sequence in your regular setting, because this is something that has been developed by colleagues, in particularly the group of Vincent Perlbach, who left academia to put together biotech. And so it's a calibrated, automated, and standardized DTI of the brain. This is all the engineering part that has been very interesting in this development. And so they look at 19 brain regions, and then basically it looks like a standard MRI, except that it's a DTI map. So you can have the fraction of anisotropy, the medium diffusivity, radial diffusivity. And this is a patient that was transplanted with just a starting of a lesion that was stable after we transplant him. But as you can see on DTI, many things happen, especially after 3 months of transplant. There are a lot of things related to the transplant. And then it stabilizes, and then it finally improves. But that you can monitor much better, of course, with your eyes. So we use this method of standardized DTI to actually, of course, analyze the effect of lerglitazone in the advanced trial. And it's still not published because we want to validate that in the context of clinical care and the daily data. But you can see clear here change in the maps of these patients once you start changing them from the placebo arm to the active, for example, at 2 years. When Marianne was using this also for the cerebral ALD part, she saw very clear differences between patients who were responders and patients who did not respond, as you can see. But what we want to use now is basically to have it as a predictive marker of conversion to the cerebral form, because in the advanced trial, the patients who converted, we could actually define an index with the RD that actually showed that there was more chance to convert when this increased. And we are trying to validate that in a multicentric study. So if you are interested in just standard MRI that should be applied, just to mention that we just had a paper published very recently by Marianne and Emo, a postdoc, on guidelines to perform imaging in patients with ALD. We are very happy that all of the centers involved in ALD, although most of the centers, and never all, were involved in that. So we propose a core sequencing with additional ones if you want to do research. And my last 1 minute left, I also would like to open a little bit our thinking in general, because I think it applies to everything else field. I love talking genetics about with Christelle. I know molecular biology is absolutely fascinating. I like metabolic pathways better because I like the rationale actually between all the different steps. But I think we're forgetting, and it's not just my thinking, too much of that, the context in which all of this happened, which is cellular biology. And more than that, there is actually a lot of physical things happening that we tend to forget in everything that happens in our brain. But to this community of HSP, I think you are very familiar to that, because this is simply transport happening on a microtubule that are associated with disorders, the tubulinopathy, but also motor domains, kinesin, dynein. And when you look at that video and you know this is carrying vesicles with neurotransmitters, with DNA, with proteins, how can you not think about the physical aspects of what is driving also biology? And we have the chance with imaging to actually cover the spectrum from looking at some molecules, from looking at metabolism with spectroscopy, but also looking now at stiffness and those physical properties of the brain with elastography. And if you think that this is kind of fantasy, just, for example, showing just an example of recent research in Alzheimer's. This is what looked a stiffness map in the brain. Of course, it changed with age. But when you look with people who are developing Alzheimer's, they showed very nicely just a year ago that the stiffness of the brain was the best predictor of the cognitive decline in this population, much more than the amyloid load or any PET markers that they had or any CSF markers that they had. So depending on how your physical properties are, you're not going to be impacted the same way in biology. And that's because I know you're interested so much in understanding phenotypic heterogeneity. I think this is an area that should be completed. And so based on that, we have been putting together a symposium, understanding physics and metabolism. If you're interested, we just published a paper last month in IA Science, and just finishing by thanking all the fantastic people in my team, from the clinical or more fundamental areas, and particularly Violeta Zujovic, who is a neuroimmunologist. And so we're doing a lot of work also on cells on this patient, not just of their brain. Thank you very much for your attention.
Thank you very much, Fanny, for this promising results and overview. I think we have time to take questions for Ralph and for Fanny. So are there any questions for the two? There's one. I will give you the mic.
Christian Romer, hello. It's not quite fair, two fascinating talks, so I have a question for Ralph. One overarching thing here is the placebo response, and you talk quite a bit about it. So these tapping exercises in rating scales, they don't work very well, produce huge placebo responses. Q-motor, you say, doesn't. Can you discuss this? Why is there no placebo response in Q-motor if I boil it down even more?
Well, I mean, to be honest with you, I had a talk at the German Academy of Neurology recently, and I left it all open, and I was so pleased somebody stood up and said, so Ralph, what you're showing there, isn't that like, so the placebo effect comes from the rater?
Of course, yeah.
So that's what I think in the end of the day this means. We have had this data very, very early. When I was a young resident, it was very difficult to tell the big professors, hey, look, I think, you know, it wasn't popular. But I think in the end of the day, when you look at the data right now, and we've done probably 15 clinical trials using these systems, I think, and it doesn't have to be just Q-motor, right? I think it's probably the propensity, like it's probably the property of all digital objective measures if they work properly. I think in the end of the day, the take-home message here for me is to digest, okay, if we can avoid placebo responses, wherever they come from. I mean, I think the data suggests they are rater-driven, because otherwise we wouldn't see what we see in the patient. So there seems to be a rater-driven bias in assessing the patients. I tell my colleagues, you know what, that makes you actually very sympathetic because you want your patients to be better, so you score them better. But in the end of the day, what I think, like practically, what you just said, like, you know, of course, I mean, if I look at that data, it's heartbreaking not to treat the people, right? You don't want to do a placebo-controlled trial. The same is true for us now in certain approaches in Huntington's. We are fairly convinced that some of that stuff we're doing is good stuff. And still the regulators tell us you need to go for a sham-controlled trial, which I, by the way, wanted to do right away. But if we would recognize and learn as the field that indeed there are technologies that allow us to avoid placebo responses, and I think the next step to think is like, do we need placebo control? So, but we need to kind of appreciate that, learn that, and educate people and get the science done and the evidence to convince us and others to do this. And by the way, don't take me wrong when I said earlier, well, this isn't accepted by regulators. That's true, that's the current status, and I think that's very much applying to what you are doing. I would always encourage people to educate regulators. So there is always, regulators today have been trained yesterday, right? So we have to, like, as a field, if we see something is new, we have to get the evidence together, we have to publish, we have to maybe use it in like Q-motor in different diseases, and then eventually we will learn. The next generation will be able to use that, and regulators may rethink. Does that answer the question?
Yeah, it does, so in part, and the regulatory discussion is something we maybe could have later, but in all fairness, if you look at the Huntington trials, the placebo response overall is quite mild. Would you agree? I come from the ataxia field, and we see in certain...
Well, I mean, we could dive into the details.
Yeah, maybe we should do that later, yeah.
Truly frustrated by some of the placebo responses. But there are, however, measures that are less placebo effect prone than others, right? So there are things, and by the way, I mean, clearly finger tapping is not going to solve the world, but what I'm saying is that it is a measure, for me, this is proof of concept. Like if I have a gene therapy, for instance, right, like the Unicure trials, it was a big ethical concern to even expose the people to that. I told all my patients, you're flying to the Mars and not to the moon, and you don't have a return ticket if you get that, right, because we can't get it out of you. So if we have something that helps us early on in such trials to read whether we hit the target, whether we have efficacy, that's great for me. And from all my clinical experience, I think cognition, of course, in all of these diseases is very important, but very difficult to measure. So if we do think that our approach actually changes the course of the disease, why not using the measure that is the most easiest to measure in order to get target involvement data and dose data, and then go on, right? I mean, we will hope that this changes cognition and other stuff as well. But I think we have to think differently about clinical trials in the future. I hope that you guys, when you have grown gray hair, you will not do clinical trials that are dependent on rating scales that are very crude. If you want to do a symptomatic therapy in an advanced stage, use a rating scale. But if you want to do disease modification, where I think we're challenged to go in early, we need something else.
So I think we have time for one other question. Jonas?
Also for Rolf. How did you deal with this thing on like the fit for purpose developing of outcome measures, like defining that Q motor is really relevant to patients? So how do you deal with that? And also defining like the meaningful score differences for being approved by regulators?
Very important questions. I mean, as I said earlier, you can argue whether finger tapping is the big thing, right? But again, it depends a bit on what you want. If you want a symptomatic therapy, you go for a specific readout. If you want disease modification, you're happy to see a signal in these slow diseases. So we want something for proof of concept. Motor in Huntington's disease clearly is something which does travel with the disease progress. And as I said, it's easier to measure probably than cognition. But we are trying cognition as well. There's another challenge. Regulatory agencies don't like composites. We have this Composite Unified Huntington's Disease Rating Scale, the CUHDRS, that I referred to. I didn't get into it because of the time, but regulators, the FDA actually doesn't accept it. There was this funny trial of Generation HD1 of Roche that I briefly mentioned where tominersen didn't really work. Interestingly, that was the first trial I learned as a clinical trialist. I was laughing when I saw the protocol because they picked the TFC as the primary endpoint for the United States and CUHDRS for Europe. It was the first phase 3 clinical trial that I had seen that had two different primary endpoints in different regulatory hemispheres. Why? Because the CUHDRS is a composite and the FDA doesn't like composites. So with the Q motor, talking about clinical relevance and also the whole aspect, we actually discussed with the FDA when we interacted with predopidine with them. We said, so what should we do? Should we just use finger tapping or should we come up with a combined score? And they said, don't use a combined score. Go for the finger tapping as the primary endpoint and then use the others as secondaries, and we'll look at the cumulative evidence. We have a concept now how to, like I told you, we have tongue protrusion for brainstem function, we have finger tapping, foot tapping. I want a combined score. Of course, I want to see this everywhere. If your drug works disease modifying, in my phase 1, phase 2 trial, I will never do a trial without a quantitative measure anymore. I will use finger tapping as the primary endpoint, but I will have everything else listed in there. And as a clinical trial, this is my decision what to do. The FDA isn't even concerned about that. Phase 1, phase 2 is us. And then we will learn, and then we will put it to phase 3, and we'll see what we use. The clinical meaningfulness was briefly kind of referred to in that one slide that I showed. I didn't have the time here to discuss this, where we actually did baseline correlations between Q motor data and the clinical scales, TFC, CUHDRS, TMS. And what we showed, and the regulators liked, both the EMA and the FDA, so we're lucky we're in interactions with them because of the sponsors, we had a very reproducible correlation between the Q motor data and the clinical scales across the very different hundreds of patients in each of these trials, which means it's very reproducible. And then you can say, okay, TFC1 is maybe, we can all agree, like those of you in the Huntington fields, a change of 1 point in the TFC is really meaningful. We don't want that to happen. And then you can say, okay, TFC1 change is X or Y in finger tapping and pronation supination tapping. That's how you get to clinical meaningfulness. However, it is very dangerous to define clinical meaningfulness in a very rigid way, because that also puts regulators to the threshold to say, if you don't reach it, even if it looks all promising, like the overall evidence looks promising, you might fail your trial. So you have to be careful about this. And regulators know. I mean, if you talk to these people, they know. I think today in disease modification trials in these rare diseases, if we come with a primary endpoint that's 0.07, and we have quantitative evidence that's 0.0001 in 10 measures, we'll get there, probably. So nobody's going to tell you beforehand.
Thank you very much. I think we can discuss in the coffee break. Thank you, both of you. And we will continue with another talk about treatment in rare diseases, a talk about Skyclarys. I think the first treatment for Friedreich ataxia that was approved. And it's Valérie Gioisa.
Yes.
Okay?
Yes, it's okay. Perfect.
From Bordeaux in France. So thank you very much for coming in. And
thank you to you for the opportunity. Good morning, everyone, and thanks for the opportunity to be here. My name is Valeria Gioiosa. I'm a neurologist, and since February 2024, I have been working at the University Hospital of Bordeaux, where I'm involved in administering omeveloxolone to patients affected by Friedreich ataxia. You may wonder why we are discussing ataxia in a symposium focused on paraparesis. The reason is that Friedreich ataxia, especially in its early stage, can therefore enter in differential diagnosis of hereditary spastic paraplegia. This disease, it was first described by Nikolaus Friedreich in 1863. It was a German neurologist, grandson of Nikolaus Anton Friedreich, that it was the first person that described the Bell's palsy, also known as Bell's palsy. So Friedreich ataxia is the most common hereditary ataxia. It's a rare disorder caused by a triplet and is autosomal recessive inheritance, affecting approximately 1 in 50,000 individuals. The carrier frequency is higher, with about 1 in 90 people being heterozygosis carriers. It is caused by a GAA triplet repeat expansion greater than 66 repeats in the first intron of the FX gene, which encodes frataxin. In healthy people, we know that the number of repeats is typically below 40. In approximately 96% of patients, the disease is due to a biallelic GAA expansion. In the remaining 4% of patients, the cause is a monoallelic GAA expansion in one allele, while in the second allele carriers a point variant or a deletion. GAA repeat expansion induces an epigenetic silencing of the gene. In fact, the expanded repeat promotes the formation of a more complex chromatin structure, which limits the excess of transcriptional factor and reduces FXN transcriptions. This genetic mechanism leads to reduced frataxin levels, which ultimately results in mitochondrial dysfunction and progressive neurodegeneration. In fact, frataxin is a mitochondrial protein that is encoded by nuclear DNA. It is primarily involved in the biogenesis and storage of iron cluster or of iron-sulfur cluster, which are essential cofactors for many mitochondrial enzymes, including those in the respiratory chain, and also in the other metabolic pathway. In Friedreich ataxia, the assembly of iron-sulfur cluster is impaired. The reduction of frataxin leads to the accumulation of free iron that, causing mitochondrial and cellular dysfunction, leads to the production of reactive oxygen species. This condition can trigger ferroptosis, a form of a cell death driven by iron-dependent lipid peroxidation. In health cells, protective mechanisms exist. For example, we know the activation of transcription factors that induce anti-inflammatory and antioxidant genes, such as NRF2. However, in patients with Friedreich ataxia, these protective responses, we don't exactly why, are dysfunctional. In fact, NRF2 expression and activity are reduced, and its ability to upregulate antioxidant and antiferroptotic genes is impaired. Thus, in patients with Friedreich ataxia, we are faced in a double insult. In one hand, there is the reduction of frataxin with the augmentation of reactive oxygen species, and in the other hand, there is the impaired cellular defense and the repair system that would normally mitigate this damage. The onset usually happens in childhood or early adolescence, although there are cases where it appears after the age of 25. These are called late onset Friedreich ataxia or LOFA. This is a multi-system disease that affects multiple organs, especially those where mitochondrial function is most severely compromised. Clinically, we can see proprioceptive ataxia caused by involvement of the sensory pathway ganglia, cerebellar ataxia, pyramidal tract involvement in approximately half of patients. It's for that could enter in the differential diagnosis with HSP. Cardiomyopathy, diabetes, hearing loss, visual impairment, and skeletal issues such as scoliosis and pes cavus. Until recently, there was no treatment available for this disease. This slide shows the pipeline of the Friedreich Association Research Alliance. I highlight the drugs currently under investigation. Among these, the only treatment approved for patients is omaveloxolone. So its arrival represents really a breakthrough in the managing the disease. So omaveloxolone is an oral activator of NRF2, the key transcription factor involved in the regulation of oxidative stress and mitochondrial metabolism, which, as we have seen earlier, is dysfunctional in Friedreich ataxia patients. Regulatory approvals are FDA in 2023 and EMA in 2024. It was indicated for patients aged 60 years and older. The clinical efficacy of omaveloxolone was demonstrated by Lynch studies, MOXIE studies conducted by Lynch et al. At the University of Pennsylvania. Let me show what happens with and without omaveloxolone. In fact, in healthy individuals, we know that NRF2 is located in the cytoplasm, bound to KEAP1. When oxidative stress occurs, NRF2 dissociates from KEAP1 and transmigrates in the nucleus, where it initiates the transcription of its target genes. In patients with Friedreich ataxia, this process is impaired, and NRF2 also, if occurs an oxidative stress, remains bound to KEAP1. Omaveloxolone, so, promotes the translocation of NRF2 in the nucleus and enabling the transcription of protective genes. Here, I want to let you show the results of MOXIE studies. In fact, these slides illustrate the change from baseline in the mFARS score over 48 weeks. mFARS is the modified Friedreich ataxia rating scales, a clinical scale used to monitor disease progression in Friedreich ataxia patients, where higher scores indicates worse neurological function. Data were compared with placebo group using the FACOMS registry, a USA based on the natural history of the patient with Friedreich ataxia. And as we can see, there were a difference of -2, c'est français, excusez-moi, but change to languages is a bit difficult. A difference of -2.40 in mFARS that corresponds to approximately 2 years of natural disease progression. So at 48 weeks, the therapeutic benefit of omaveloxolone is robust, statistically significant, and clinically meaningful, particularly in upper limb coordination and upright stability. So this represents the first treatment to demonstrate a real impact on the functional progression of Friedreich ataxia. So it's normal that there are side effects, but omaveloxolone was generally well tolerated, with few side effects reported. Most adverse events occurred during the first 12 weeks, and treatment were generally mild. The main area that we have to pay attention is the liver function, because some patients showed an increase of AST and ALT. Thanks to French High Authority of Health approval, France became the first European country to administer homeveloxolone to patients with Friedreich ataxia who meet the eligibility criteria. On this map, we can see the relationship between the number of prescribers and the number of patients, which provide a concrete understanding of the distribution and organization of treatment in France. Bordeaux accounts for approximately 50% of all treated patients in the country. Let me show what we did in clinical practice. So, all patients between January 2024 until now are evaluated at the University Hospital of Bordeaux, with clinical evaluation at beginning, at 3 months, at 6 months, and then every 6 months. Blood samples were collected, cardiac eligibility criteria were assessed, genotyping was performed, and statistical analyses were conducted. In France, unlike the USA, the scale for the assessment and the rating of ataxia was used for the assessment because it was a bit easy to handle. The scale includes 8 items that explore gait, speeching, standing, balance, and limb coordination, with 0 that indicating no ataxia and 14 that representing a severe impairment. Our cohort included 32 patients, 30 men and 90 women, with a baseline SARA score of 23.5. The follow-up duration was 18 months, but 3 weeks ago we started with examination after 2 years. We implemented a close multidimensional monitoring approach, so clinical evaluation performed using SARA and SF12, that is a score for the quality of life. Biologically monitoring at beginning, at the first month, the second month, the third month, and 6 months, and then every 6 months, including liver function, lipids, and cardiac checks. Annual cardiological assessment was performed, and all patients received a standard dosage of 150 mg per day, with a dose adjustment tailored if transaminases level increase or if it was necessary. This protocol allowed us to carefully track patients' outcomes and ensure safety throughout the treatment. So, moving on the results of our cohort, regarding the clinical outcomes, as you can see, we observed a statistically significant improvement in the SARA score, particularly between baseline and the 3 months, and 0 and between baseline and 6 months. But at 12 months, there is a return toward baseline values. And this is what it was described in MAXI studies. This becomes even more evident when we compare the results. I don't know if it's the first image. When we compare our results with the European Natural History Register, that it was IFAX. In our cohort, in fact, we observe an initial improvement followed by a stabilization toward the baseline values. In the context of a progressive disease, also a stabilization represents a strong positive signal. The side effects were generally mild and mainly consisting of elevated transaminases, sometimes requiring a dose reduction or temporary interruption, as I said. Triglycerides and cholesterol remains elevated at 18 months. No unexpected severe events were observed. So, in conclusion, homeveloxolone is the first molecule to demonstrate a clinical efficacy in Friedreich ataxia patients. Results are encouraging, even if not miracles. So if it remains crucial to understand the disease, recognize it early, and refer patients to specialized centers where multidisciplinary care can be provided. Our experience at the University Hospital of Bordeaux confirms the results of MAXI studies with an initial improvement followed by a stabilization of the disease. Continued treatment is essential to observe long-term effects, but especially real-life effects. So it will be highly valuable to identify biomarkers, it's clear, because we use a score that is operator-dependent, and we need biomarker, and the best it will be used also cellular-derived fibroblasts in order to examine what happens in patients' cells. And I would like to end with sharing to you this little story. This is a patient that I have been following for 2 years. And he gave his consent to publish these photos, for which I'm very grateful. Every time he came for a visit, I would ask if anything had changed since the last time, and every time I expected the answer like, yes, I changed my blood pressure medication or I increased my physical therapies. But instead of that, every time his answer, he takes his phone, and his answer was, yes, doctor, I started paragliding, then I started go-karting, I don't know why. Okay, I started go-karting and start diving, and I start to climbing. So I believe really that this story is a wonderful example of hope for patients who until now did not feel properly cared for. And thank you for your attention, and would like to thank all my colleagues involved in this work, Professor Cyril Goisier, Professor Carlo Casali, Dr. Chloe Angelini, and all the people that work in the laboratory, Giovanni Stevanen, Manon de Coutin, it's here. And I want especially thanks to the patients. Thanks you.
Well, thank you very much. We will take the questions after the second talk. So I think it's great to have so many talks about treatments in rare diseases. Several years ago, we haven't had that at the symposium. So next speaker is Professor Mate Synovczyk from Tübingen University, who will give us some insights in treatment options in one of the latest discovered cerebellar ataxia, but one of the most common. Will work? Yeah.
Yeah, thank you very much, and in particular, Family Walik, for inviting me and once again hosting a wonderful symposium. Thanks for all your efforts that you're doing for the field. So we're staying in the ataxia field and staying in some treatment approaches. I'm going to talk about SCAR27B, and I'm going to propose two treatment approaches here at different stages, but both I think of interest. Just as a disclosure, I do receive consultancy honoraria from Solaxa. This becomes important later on, so just to flag that clearly. What is SCAR27B? SCAR27B, I still have to remind myself, was just found in 23, in particular by the lead of Stefan Züchner's team. So it's still quite recent, but it is so frequent that even in the very same year, still in the early 23, we were able to map, at least retrospectively, the natural history and map that. And very soon it becomes clear that, at least in the Western European countries, it's so frequent. So we mapped this systematically. In autosomal dominant ataxia, you see in blue, it is the, at that time, it was SCAR3 was the most common SCAR, but now we think SCAR27B is at least as common as SCAR3. So SCAR3 is no longer the most common genetic ataxia, but it is SCAR27B. And we just in Tübingen, we have by now 75 SCAR27B patients. That is an autosomal dominant ataxia cohort, and what is even more striking, or somewhat strikingly, what's the case in sporadic ataxia? And we were looking systematically in the consecutive cohort of sporadic late onset ataxia. So that's really the cohort you don't want to look into if you want to look for genetic diseases. So they're the most de-riched patients to look at. And even in this most de-rich cohort of patients, late onset, sporadic, so really you don't expect to find anything. We find 12% SCAR27B, and which is even more than RFC1. So even in sporadic ones, and I think this has been you guys are finding this. So I think so. That's important for you in clinical practice. Even if you have your classical late onset ataxia patient, family history is negative, look for SCAR27B. And it's such a game changer. And the clinical phenotype is a little bit, first it seems remarkably unremarkable. It's a late onset disease, later than most CAG repeat expenses, median onset about 60 years, often sporadic, as I said, 48% in an autosomal dominant gene. 48% of our genes do not have a positive family history. And that in autosomal dominant gene, it is slowly progressive, about 0.4 Sarah points per year. That's much less than even the slowest CAG repeat ataxia, which is about 1.5. So it's much lower than the CAG repeat ataxias. What is interesting is, yes, there are some with not optimal sensitivity, but there are some signs which do help you clinically to predict SCAR27B apart from the late onset and the slow progression. It's the presence of downbeat nystagmus, it's activity-triggered episodes, so activity-triggered exacerbation of the ataxia, and that might be prior to onset of the chronic phase. And we even have some patients who were diagnosed as having repetitive neuritis vestibularis, vestibular neuritis, or atypical vestibular neuritis, because they have the onset a few days and goes onset days, and then it becomes the chronic. Or it could be part on top, like for CACNA 1A, you're on top to the chronic phase. You have the chronic phase and then acute episodes on top, but you have either one. They have a remarked alcohol sensitivity. They're like this patient from Ludger. And there is about 50 to 60% have a certain MRI sign, which is called the superior cerebellar peduncle sign, SCP sign. 50 to 60% for Macondas, for your ataxia reviews, you can highlight that one. So it's still only 50 to 60%, but it is helpful as there are very few other ataxias who have this. Polar 3As might be one of them, but very few other ataxias have this MRI sign. And what is remarkable is that it is largely pure cerebellar. So as opposed to SCAR1, SCAR2, SCAR3, which have whatever, Parkinsonism, motor neuron affection, cerebral neuropathy. SCAR27B does not have this. So the absence of this is also a helpful cue to clinically identify this. So we're talking about, I want to go to treatments now. So what we found already in 2023, right when finding the gene, we thought, oops, when looking at the cohorts, we saw something. We saw 7 patients in our cohort had received foraminopyridine, and that was something which was haunting in the ataxia world for 10 to 20 years. We always had the clinical observation, there are ataxia patients who respond to 4-AP. And we did the trial or the case series in 2010-11, and we did the trial, it was negative. That was just because we did not know who was it. We just lumped into the trial any ataxia patient. We did not have the genetic stratifier. And then bam, there it was. It was 6 out of, so there was 3 suspected open label data, 6 out of the 7 patients who reported response to foraminopyridine. So it was a gene which was stratifying the responders. And there was even one patient where the health insurance did decline, did approve the foraminopyridine cost coverage. So this patient went on, off, on, off. Not that we wanted him to go on, off, it was by mere practical financial things. And this is remarkable, though. We made him do a protocol because we want to convince the health insurance company this drug is working. So he was on, off, and off. And this is like levodopa, levodopa for Parkinson's. So we have a little bit now the levodopa for ataxia, at least for SCAR27B. So you have a rapidly responding, non-responding ataxia drug, like levodopa. Of course, this is open label data, so you have to take it with caution, but still of interest how this is. So, which means you can really do symptomatic trials. You could even do, in principle, on-off trials, and that has not been heard of in the ataxia world before. So that was a small case series, and then we looked into another cohort, a cohort with, defined by downbeat nystagmus syndromes, plus minus additional cerebellar ataxia, but the defining feature was downbeat nystagmus. And what is of interest is we checked also this cohort for response to foraminopyridine. Interesting, all those patients were on foraminopyridine prior to the gene SCAR27B being known. So naturally, both the clinician as well as the patient were blinded to the underlying genotype. So we do have, we have a little bit like a retrospective blinded trial, so to say. And what is of interest is that, first of all, look at the left side. Those are the SCAR27B patients. The standard threshold is more than 250 GAA repeats, and 81% of those downbeat nystagmus patients who had a repeat expansion did, on a clinician-reported global impression, did have response to this. And this is much more than the non-SCAR27B patients. And that's of interest because if that was, we were discussing placebo right now, is if it was a placebo response or it was a rater-driven placebo response, then you would also expect the non-SCAR27B patients to respond, right? Because the rater were blinded. They didn't know, is this SCAR27B patients or not? Because they were blinded to the genotype because the gene was naturally not known. So it's like a naturally blinded trial. So that's of interest. So there is a true signal. It's not only, despite the fact that being open label, you're blinded. So there is a true response. What is also of interest is that in those patients with a GAE repeat expansion between 200 to 249, they show they're indistinguishable. So they have a high amount of patients responding, and you see the same numbers, just a little bit lower in terms of absolute numbers, but the same pattern you see not for the clinician-reported outcome, but for patient global scoring. They're also, again, high response of the SCAR27B patients, poor response in the non-SCAR27B patients, so no placebo, and the same as in the classic more than 250 repeats, you see in the 200 to 249 repeat patients. So this is clinically or treatment-driven evidence for the fact that that is clinically driven or treatment-driven evidence for the fact that we might need to go or might want to go lower with a threshold. There is biological and genetic evidence for this, but this is like a treatment-driven argument that the threshold for SCA27B might actually not necessarily be 250, but 200 GA repeats. And we're now trying to play this out further with Stefan Zuchner and others, but stay tuned, I think the threshold will become lower. But going back to the treatment, we have those clinical observations. Now, we ask in our lab at the Hertie Institute of Tübingen, we ask what is the underlying mechanism of action of 4-aminopyridine? And then we look into the pathophysiology and the isoform of FGF14, the mutated transcript in SCA27B. It hits the isoform 1B, and this isoform is expressed in the cerebellum. And what is important is that this isoform has in its N-terminal region, it is responsible for the regulation of sodium channels, so voltage-gated sodium channels, and via regulating voltage-gated sodium channels, it does regulate rhythmic firing of Purkinje cells. So that's already has been known before. So here you see a graph of this, and you see sorry, it's a little bit small, but what you see is in blue, you see FGF14. So FGF14 is not an ion channel protein per se. It's a fibroblast growth factor. It's like a structural protein. But what it does, it does bind directly to the voltage-gated sodium channels and thus modulates voltage-gated sodium channels. So you could conceptualize SCA27B like a secondary or tertiary ion channelopathy. Not a primary, but a secondary or tertiary one via this link. And this might give you a clue why is 4-aminopyridine working, despite the fact that FGF14 is not an ion channel protein, but a structural protein. It is via this binding to voltage-gated sodium channels. So is there evidence for this? We looked in the lab, and that is worked together with a group from Holger Lerche from Tübingen, is a clinician scientist from our group, Felix Skell, looked in 2 patient lines, iPSC-derived neuronal lines, and in 2 cortical neurons. He did fluorescence microscopy and whole cell patch clamp recordings. I'm only presenting some of the data from the whole cell patch clamp recordings. But what he was able to show, and this is just an illustrative graph, is that you have a control up here, and what you see here is that a heterozygous SCA27B patient, the firing rate is less than compared to control. Now, if you give 4-aminopyridine, you see that the firing rate is as good as the control. This is exemplary data. How does this look on a more systematic level? You see in bright gray, you see the control. You see on the bottom in orange, you see the patient. You see the action potentials of the SCA27B patient is reduced. And then you give 4-aminopyridine, and what you see in the bright orange is that the patient gets back to the firing rate to the control level. So not only is it restored qualitatively, but indeed the firing rate is being brought back to the control level by 4-aminopyridine. So that's evidence really for the mechanism of action that even in in particular in SCA27B, the firing rate is being restored by 4-aminopyridine. So this gives us an insight into what we see clinically, what might be the underhappening mechanism of action. So what is the next step in the field? What should we do? It's great that we have this off-label use, that we have this clinical data. I think we now have to bring it from off-label to on-label to get to market approval. And in order to do so, we have to do a pivotal trial. This pivotal trial is currently being prepared by Solaxa, and Christian Romney is part of the team as well. And the trial is called 301 trial. The primary outcome is going to be the upright stability scale, or FARS-E, of the mFARS score. It's a parallel group design trial, but 12 months, and let's see how this is going to evolve. It is planned to start this year. And I think once we have this on-label, we'll be on the first on-label drugs for an autosomal dominant sex. I think that would be a game changer in the SCA world. So that's great. 4-aminopyridine is great. It does work nicely. It's great, but it does not act upstream of the disease course. It does modulate the ion channels, but it does not act upstream. So could we come up for treatment with SCA27B, which indeed targets the root cause of SCA27B? So what's the root cause of SCA27B? SCA27B, as I've said, is an extension, a GAA repeat expansion, and the proposed mechanism of action of the GAA repeat expansion is that the polymerase cannot read through this extended GAA repeat, but there's a transcriptional stalling by the GAA repeat. The polymerase gets stalled, and given that it's stalled, the protein is not being built, so it's a type of a transcriptional deficiency. So
if this, however, is the case, why not give a small molecule which allows a polymerase to read through the GA repeat and thus overcomes this transcriptional stalling and thus allows for the FGF14 protein to be rebuilt? So might this work? And yes, there is case evidence from Hereditäre, which is also a GA repeat expansion, and the drug is called Sintef1, which is a transcriptional factor which might allow the polymerase to read through the GA repeat and thus overcome this transcriptional stalling and thus reduce the restore the transcript, the protein, and thus function. That's a hypothesis. Is this hypothesis true? I think Felix has brought up some evidence. So first of all, if this hypothesis was right, the first readout to look is the transcript being restored upon Sintef1 treatment? And yes, you see here a heterozygous patient on the right hand, a biallelic SCA27B patient, so having two SCA27B repeat expansion, even though being an autosomal dominant disease. And what you see is, relative to wild type, is you see first the heterozygous carrier has a reduced levels of an FGF14 transcript prior to Sintef1, and then upon Sintef1, it's restored to a normal level. And that is true for the heterozygous carrier, and it is true for the biallelic carrier. So yes, first of all, this does underline confirms the pathophysiology, upstream cause of SCA27B, the reduced FGF14 transcript, and yes, this transcript is being restored by Sintef1. Now, is this restoration of the transcript, does it also lead to the restoration of neuronal functioning? So is it not only target engagement, but is it at least cellularly meaningful? Not clinically, but cellularly meaningful. So Felix was looking at the whole range of downstream elements on the readouts on the cellular level. And indeed, Sintef1 was increasing the action potential firing. You see the untreated on the left in gray. You see upon Sintef1 on the right. You see the sodium currents. Sintef1 does restore the peak sodium current. Again, untreated on the left, treated on the right. And another cellular readout is synaptic transmission, which is interesting that SCA27B is not just an ion or secondary ion channelopathy, but also does impair synaptic transmission. But also as an electrophysiological readout of synaptic transmission, evoked EPSC amplitudes, they are decreased in an untreated state and then get restored upon Sintef1. So Sintef1 does wire allowing the polymerase to read through the GA repeat, does restore the transcript, FGF14 transcript, and this leads then to that also the cellular downstream effects, all those downstream get restored. And I think that's quite promising. I mean, I think the clinical thing is now still to be done, of course, in vivo talks and so on, but I think that there's at least preclinical evidence that there might be an upstream target druggable by an existing, now in phase 1 for Hereditäre drug for SCA27B, which might be disease-modifying, targeting the upstream cause rather than just the ion channelopathy component of SCA27B. With this, I want to thank all of you, thank my lab, and we had many collaborators, in particular David Paneron, now with Stefan Züchner. David is a great guy, and Stefan Züchner, so it's a great team to work on SCA27B. Thank you.
So thank you very much, both of you, for this inspiring talks. Are there any questions from the audience? Many questions from the audience. We'll start with Ludger.
Perhaps the first for Mattis. You mentioned that SCA27B is fluctuating ataxia. There are fluctuating aspects. How do you want to deal with that in your trial? As far as I remember, and you have shown the patient, it's dependent on daytime, but not reliably. There are other factors that influence it.
Yeah, no, that's absolutely true. I mean, we try to normalize and standardize the assessment as much as possible, so same day of the same time of the day and so on. The thing is even if it was fluctuating, we would not expect to have that systematically to occur at one of the pre-treatment, post-treatment time points, but it might increase pre-treatment or post-treatment. So it would increase noise to our data and thus increase the sample size, but per se it would not confound the treatment effect if we saw per se, because it would affect both baseline and post-treatment and would affect both placebo-treated as opposed to non-placebo treatment. So we would not have a systematic effect, it would just add noise. But that is something we would have to deal with this, that's true, yeah.
I'd also have a question from Mattis. Thanks for this. obviously I know nothing about the disease, nothing about the gene in particular, but I know that these GA tracks are really the same issues that we see in the polymerase of the sequencer, where our coverage drops in PacBio. So this could be the treatment to fix that technical issue, so we need to discuss that with PacBio.
Could add it to your buffers.
But the biological question to that is, there's other parts of the genome where we have these GA tracks. So have you checked by genome-wide transcriptional profiling of your patient cells or patient material, whether also other targets respond by a better read-through of the polymerase, and you get misregulation of other genes or loci?
That we have not systematically checked, but for example, the Friedreich, maybe the free, I mean, that we have already well-known GAP reaction. The thing though is what we do is we, for example, do check, so what would be of concern? Of concern would be toxicity. It would be a potential toxicity driver. But if at all, there seems to be what we see in controls is if we also treat the controls cells with SINTEF1 there seems to be natural barriers. You cannot, so you cannot increase the transcript even more. You cannot boost the polymerase from, if it reads through, it reads through. You cannot up boost it. So if you do not have a GA repeat expansion, it does not, there's a natural ceiling there. But yes, the toxicity studies will have to show it for, in particular for off targets.
So it could be indeed in certain cell types where a GA locus is not on at all, you switch it on by the drug, and that may have other side effects. So, and by now sequencing RNA-seq by long rates is so easy.
Yeah,
so maybe that's something very easy to do.
No, I like it.
To check that.
Yeah, but just maybe discussing on the toxicity stuff. It's not completely a question, but the good thing though is, at least for the SCA27B world, is that we have an FA, the phase 1 trial now, so we get some human toxicity data. And actually, the first part of the trial, the first instance of the FA trial was toxic. However, that was an acute effect in phlebitis. So it was an acute inflammatory. It was nothing with likely GA. But yes, that would be great for clinical data to check for off-target effect by long read. Thank you.
Great talk, thank you. Just want to correct something about the GAA. So actually, it's very different than from the frataxin. Because if you transcribe the frataxin, the GAA is in the gene context. In FGF14, it's not a GAA. It's a CTT. The GAA is in the genomic context, because the gene is on the reverse strand. So does it mean that what we just discussed is still valid? Is this, it's not a GA, it's a CTT?
It is, yeah, but that is the analogy we're working with, and the preclinical data, it shows as well. It works as well. So the polymerase gets stalled, and with SINTEF1, you do allow the read-through.
Completely different context. I want to put my placebo question in context also. So these case studies with omaveloxolone in patients, they're really interesting, and I like the success stories, but you described it yourself. There's a very different response in the domains of the scale in the study. And the data that you showed did not look at that at all. And I think it's extremely important to show the differential response in axial versus appendicular scores.
So in our study, the most important improvement, it was in the bulbar function. The patients have an improvement in the dysarthria and the swallowing. And it was also a bit funny because when I arrived in France, I don't speak French. And after 3 months, patients speak well. And I asked if it's the patient that starts to speak well, or if it's me that I understand better. But so,
no, like I said, I like the story, but we need to see the curves. We need to see the curves of the appendicular function and the axial function, because appendicular function is extremely prone to placebo response, huge one after 3 months. Axial function in Friedreich, they can't train that as well because they lack the response. I just learned that. So we need to see the curves.
We need to do that. Thank you for the...
No, this is important because patients look at this and they don't really understand it, and then it becomes a much bigger thing than it may be.
I'm totally agree with you, and we have the data, so we can do that. Thank you.
So maybe one last clinical question to Matthias. Should we test all our MSA patients MSAC patients without any signs for Parkinsonism, or only slight signs for Parkinsonism?
The short answer is yes. The long answer is I've forgotten the data, but Danique Bayer from my group, we have looked at MSA patients for scandianism. I'm just lying about the numbers, but we found 3 or 4 clinically probable MSA patient with SCA27B. And this is, of course, not saying that SCA27B causes MSAC, but I think should do this because and for two reasons. One is we might have phenocopies in there, and the other thing is also we do find those double hits, so the double problem. Now, a patient might even have MSAC and SCA27B, and for both reasons. But why we should do it is not just for diagnostic purpose. Now we can at least help a little bit our otherwise not treatable MSAC patients, because now we have a treatment. So I think, yes, we should do it.
And probably all the long survivors of MSAC.
Yeah, in particular those, yeah.
So thank you very much for this very, very inspiring session. So we have a coffee break now. I have to look up So I think we will restart at 11:15. Okay, 11:15? And thank you very much.
Test.
Great. Time to start, please. Have a seat. You first. Yeah, okay. Take a Vespa. Ja, Fanny? Ja. Ja. Sorry, we have to store this. Yeah. Okay. Please have a seat, and we will have to start for the second part of our morning section. We keep going translational, and it's my pleasure to invite to the stage Dr. Guido Goy. Guido, a good friend of us, and is also expert in neuroimaging features in children with acute myelitis, but he leads a very interesting study group on CLN3, Batten disease, in which he can study the influence of immunomodulation therapy, fingolimod, on the brain, volume, and other disease outcome. Guido, the stage is yours, please.
Yeah. Thank you very much for the introduction and the invitation. I'm going to present the results of our interventional study, influence of fingolimod treatment on disease outcome and MRI brain volumes in children with CLN3. The CLN3 is the juvenile form of 14 different inherited forms of neuronal ceroid lipofuscinosis, which as lysosomal storage diseases are characterized by the accumulation of autofluorescent lysosomal storage material, especially in neurons, but also in the retina, in the heart, and in liver, kidney, and adrenals. The juvenile form I'm going to talk about is characterized by disease onset at the age between 4 and 6 years, starting with a loss of vision, progredient loss of vision, and then followed by a cognitive decline and behavioral abnormalities. Epileptic seizures usually occur at the age of 10, and later on the children suffer from movement disorders, speech difficulties, and mostly die in the 3rd decade of their life. This picture of a patient I can show with the permission of the NCL Foundation. Typical concerning brain imaging is the cortical atrophy, which you can see on this picture of a 15-year-old female patient before treatment. And now the background of our study were mainly 2 research work. The first one was the one of the study group of Professor Martini and Janos Groh, who has shown in autopsy brain sections and optical nerve sections that there is a secondary neuroinflammation taking place with the elevation of especially CD8 plus T cells, but also with a microglia activation, and that fingolimod as an immune modulator, but also teriflunomid, can ameliorate the disease course and the brain-related symptoms. So what they did is they treated CLN1 and CLN3 mice for 6 months, either with fingolimod or with teriflunomid, and then measured brain atrophy and retinal thinning. This is just, the next one shows just the mechanism of action of fingolimod. It's a drug which is well known from the MS treatment as an immune modulator, and the modulator of sphingosine 1 receptors. and it inhibits the egress of lymphocytes into the blood circulation and also the immigration into the central nervous system, thus inhibiting the inflammatory reaction. And what you can see here is that the CD8 plus T lymphocytes in this study of Professor Martini almost went back to normal when the mice were treated with either fingolimod, FTY20, or with teriflunomide. And on this illustration, you see that the brain atrophy of the CLN1 mice also came almost back to normal in the treatment groups, in the treatment mice. And below you see by autofluorescence that the storage of autofluorescent lysosomal storage material was not reduced by the inflammatory immunomodulatory treatment. This is shown by the bright green colors here, which are persistent in the treatment groups. So concluding from this, we can say that, from this former studies, we can say that fingolimod in mouse model is a secondary disease modifier, but is not affecting the primary disease abnormalities. So the second background was the natural history study of the Hamburg group, Angela Schulz and Hochstein, who measured MRI brain volumes in patients with a CLN3, and they found that there is a loss of brain volumes, especially supratentorial gray matter, over time. And this is correlating with the age of the patients and also with the clinical scores, and thus they concluded that the loss of supratentorial gray matter is a sensitive marker of disease progression. So starting from this, we initiated the study in 2022, treating 10 patients with genetically confirmed CLN3, and the purpose of our study was to find out if fingolimod applied to these patients can influence disease progression in a positive way by attenuating the progression of brain atrophy. So meanwhile, this patient group has extended to 15 patients, and the studies, MRI studies, were done annually, and complementary, we were doing cognitive testing and applying the Hamburg JNCL score and NFL measurements at yearly intervals. Now we have meanwhile also added the 6-minute walking test, but that's not part of this presentation. And on the initiative of the patient, we have added in the majority, in 8 of 12 patients, miglustat to the fingolimod treatment. And the background for this is that we know from the study of Chen in 2023 that cholesterol accumulated in lysosomes from CLN3 patients accumulates to a comparable extent as in morbus Niemann-Pick type C, and as miglustat inhibits the formation, the synthesis of cholesterol and glucose sphingolipids, it is a therapeutic option which has been proved in the phase 1/2 trial with good tolerability and stabilization of motor symptoms over 6 months treatment and reduction of neurofilaments. So here you see the distribution of our patients. 8 patients were treated with fingolimod and miglustat, or are still treated. Looking from now, 4 patients now exclusively get fingolimod, and 3 patients are treated with miglustat alone. So now, after 3.5 years of follow-up, we have now come to a point where we could do statistic analysis. So we had now collected 47 natural history and pre-treatment MRIs from different centers international in Europe. and of 15 natural history controls, and we have compared them to 31 MRIs of 15 patients under treatment and to 1,285 MRIs of the NIH group. And here you see first the box plots. You see that we've measured here the normalized whole brain volume, and you see that this whole brain volume is in the combined treatment group, and the patients treated with fingolimod and miglustat is comparable to the NIH reference group, and that in the fingolimod treatment group, brain volume is strikingly lower, and also in the non-treatment group. So the same is true for the grain volume, gray matter volume normalized, and also for the measurement of the cortical gray matter volume. So the next pictures show the dependence on age. You see here in the gray line the NIH group, and in the dark blue line the combined treatment group, which shows the best whole brain volumes over time. And there you see the non-treatment group in the dark green color and the fingolimod group in the light green color, which did not show any improvement of brain volume over time. Almost the same pattern for the gray matter, and the same tendency for the cortical gray matter, which is most sensitive for measuring the disease progression in a natural history study. So applying linear mixed effect models with an independent variable age at MRI and then the brain volumes on this axis, we see that in both treatments group there is the biggest or the best brain volume combined to the fingolimod treatment group in blue, which overlays the red line, the non-treatment group. So there's almost hardly any difference between the non-treatment group and the fingolimod group. Here it is quite similar for the gray matter volume, and here for the cortical gray matter volume. So then we had a look at the change from baseline, and here before treatment characterized as 0, and here you can see that there was one patient under fingolimod treatment in green color showing a temporary increase of brain volume, but then a decrease again, and there was actually over time, over months from baseline, not one patient who showed a permanent increase or stabilization of brain volume or brain volumes under fingolimod treatment. Here it is for 10 months to 40 months. You see again both treatments show better result than the fingolimod treatment group. The miglustat treatment group we could not really analyze because it just consisted of 3 patients, so it was not statistically relevant. Then we had a look at the Hamburg score, the clinical score, and there you see again that the Hamburg score decreased dependent on age because of disease progression, and that the Hamburg score values were better in the both treatments groups for miglustat and fingolimod than in the non-treatment group and then in the fingolimod treatment group, here again overlaying the non-treatment group, so almost the same. And here we have done the same for the NFL measurements. NFL as a marker of neuroaxonal degeneration was increasing in all 3 groups depending on age, and the values were lowest in the both treatments groups, so there was obviously a beneficial effect on neuroaxonal degeneration by the combined treatment. Fingolimod was in between, somehow improving these NFL measurements, and the highest measurements could be taken in the non-treatment group. So, summarizing the results, we can say that fingolimod and miglustat, both drugs, were well tolerated. There were no dropouts of the study. We had no increased rate of infections, no raised liver enzymes. The loss of whole brain gray matter and cortical gray matter volume over time was not attenuated by the treatment with fingolimod alone compared to natural history controls. Yet the combined treatment with fingolimod and miglustat seems to have a beneficial effect on the reduction of brain volumes over time compared to natural history controls. And the age-dependent decrease of the Hamburg clinical score and the increase in NFL values could be observed in all three groups, treated and non-treated. The Hamburg clinical score was highest in the combined treatment group and almost equal in the natural history and the just fingolimod treatment group. And the combined treatment and also the fingolimod treatment alone had a beneficial effect on the predicted NFL values with highest beneficial effect again for the combined treatment. And last but not least, fingolimod, as we know from the patient's report, has a beneficial effect on neurobehavior and psychiatric features in 8 to 12 patients. Unfortunately, we did not measure this with standardized testing, but these 8 parents reported on improvement of sleep, hyperactivity, impulsive behavior, hallucinations, anxiety, and distinctively referred this to the treatment with fingolimod and not with a combined treatment of miglustat. And in conclusion, we can say that fingolimod, as far as we know by now, does not prevent brain loss in patients with CNN3, but has a beneficial effect on neurobehavioral features and NFL values, and that the combined treatment of miglustat and fingolimod may be a promising option to decelerate the brain volume loss and attenuate the disease progression in CLN3 until a causative treatment is available. Thanks to Professor Ostasi, who initiated the study but cannot be here today. Fredrik Bartels from Charité in Berlin and Annette Eigner, who did the statistic analyzations. Markus Otto did the NFL measurements. Andreas Panzer from our radiological department. And also thanks to all international cooperators who provided natural history MRIs to complete the study, at least as a first step, and of course to the families who really challenged us to go new ways of treatment, who were very hopeful, very encouraging, and also very challenging just to go on. Thank you.
Thank you, Guido. We will have a common Q&A end section at the end, so we have to wait for the end of the section, okay?
Okay.
Then we move to next speaker. Okay, we move to next speaker, Tim Rattay, nice to see. And Tim is head of the Center for Rare Neurological Disease at the University Medical Center of Kiel. And he's an expert in precise symptomatic characterization of genetic HSP, and we'll talk about physical therapy, okay?
Just 1 second. So, thank you for the kind words. Thank you for Henry and Susanne for the invitation and the organizing committee. Do you see that? Oh, I would like to start in that beautiful city of Recklinghausen, what Recklinghausen is lacking. That's my daily work, route to the work. So when I'm bicycling every morning to work, I'm passing, originating from Naukiel, the Förde, and that's how it looked like the week before the season of Advent. But I'm presenting data today from Tübingen, so that's actually what the corporate identity outlook should look like. So I'm presenting data from a physical therapy study which we did together with Ludger and also back then Rebecca. And I would like to talk about physical therapy. Why physical therapy? With the talk today, I would like to address a clinical problem we have as clinicians, then say something about the clinical or current evidence in HSP, present some data which is unpublished from our physiotherapy study, and also address two running upcoming physiotherapy studies which will be finalized as when you believe the clinical trial entries by the end of this year. And then I would like to have a broad or short outview if all the problems are now solved. So what is the clinical problem? When you're sitting in a specialty clinic and you have patients sitting in front of you, what to tell patients with an incurable disease? So we have only symptomatic treatment, besides very, very small, limited numbers of genetic curable ones, but we need evidence. And the questions what patients ask us is, what shall we do? And the thing is, what we say is, do physiotherapy. And then they ask, what kind of physiotherapy? And why should we suggest something that is not properly tested and we don't know what they should do? So this was like the main point or the main reason why we wanted to do a randomized control study to prove that physical therapy is helpful or good for patients in HSP, and also address the question what kind of physiotherapy they should do or which exercises they should do to make them better. And at the end, there's always a question, does it make a difference and how large is the effect? Is it worth it? So I'm not talking about gene therapies, I'm not talking about antispastic agents, including baclofen and comparable substances. I'm not talking about botulinum toxin, which are established symptomatic treatments, and I'm not talking about surgical treatments, but I'm trying to show you the evidence which we had starting into that trial, and let's start out with the studies which are out there. There was a simul training with augmented reality. That's the PMID where the results were published. That's how that study would have looked like, so that you get an impression what they were doing. And what they were doing is they treated patients for 10 hours in total, and they had two arms with a total of 36 participants, and their controls were patients waiting for the treatment. They called it a waiting list. They did not show any improvement, but when they merged the group at the end, they were able to show a little bit of an effect, so probably the study was underpowered. When you look into the literature, there's another study called hydrotherapy in HSP. There is not any picture of what they did, so I asked AI to generate me a picture about hydrotherapy in HSP. That's what AI thinks how it could look like. And if you look into the study, there's not a single word what specific exercises were performed. And I think that's a major trouble. If you tell a patient do hydrotherapy and they don't know what they're supposed to be doing, that's basically helpless. So this was a very small study with only 9 participants. They had no controls, but it had a post-intervention analysis. So what they could show is that walking speed increased by 11%, through increased range of motion. They also showed range of motion data, and at least there was a little bit of evidence that could help, but it would have been helpful to point out what kind of things they were doing in the water. Then there's another study which was done a year later, I think in 2015, robotic gait training. Again, how does it look like? It looks like this. They did a 6-week robotic-aided gait training protocol with that Locomat from a Swiss company. And they had 13 patients included, no controls again, but they did a post-interventional analysis, so also not a randomized control study. And what they could show is that they had improved balance using the Berg balance scale as a clinical scale as outcome, and they also looked at gait speed, but which improved, but they had no change in spasticity. But a thing what was nice in that study, they looked after 2 months again, and they could show that at least this effect was ongoing. There is a little bit further evidence in a published study in movement disorders from 2021 in combination with botulinum toxin. But since they included patients or they even started botulinum toxin, I didn't want to address that study in detail. So let's talk about what we did in Tübingen with that physiotherapy study. It was randomized control, and we controlled it against standard care. So basically all the patients received what they had received beforehand. We did not change any medications, but we excluded patients which had botulinum toxin, but if they were on an antispastic agent, they were allowed to continue that antispastic agent, but we did not allow any changes in medications during that time. It was a 26-week study planned. We had a baseline with the randomization, then the first training, then we had like a refresh training booster after 2 weeks, and then we had a 12-week follow-up and a 26 follow-up, and the primary outcome measure we used was the spastic paraplegia rating scale, and as secondary outcomes we looked at the goal attainment scale as a meaningful outcome for patients, as well as a 3-minute walk test. What was the main idea of the study is we had a catalog of 26 study exercises we had, and this was targeting basically 4 main domains. The first one was the neuromuscular target, so trying to reduce the spastic muscle tone. The second was strengthening, so look at muscles or muscle regions which are weak and try to improve them. Third one was increase the movement ability, so the passive joint range movement. And the last one was a functional one with gait, postural balance, and coordinates. I have only a picture of the German translation of the 26 exercises at the moment, but that's one of the things we need to address when we want to roll that out internationally. Those are exercises, the first 4 out of those 26, which we had, and those exercises were based to target basically every patient in HSP. So from first or very early in disease with lots of function still available, up to people sitting in a wheelchair, and even exercises addressing them. So what we did is, together with the physiotherapist, we selected up to 11 personalized exercises based on baseline deficits and patient preferences, and fine-tuned then that with difficulty levels, and they had supervised 10 hours physiotherapy in 2 days with us, and then we had that boost after 2 weeks. And when looking at the baseline characteristics of that study, we had a little bit more males than females, but not significant difference. They were at the age of about 52 years, so somewhat in their disease. I have the disease duration was in a median of 20.9 years, so that's what we usually see at that age, and their median SPRS score was about 15. So when you look at the total SPRS score, which was our prime outcome measure at that time, and you do a paired ANOVA with those patients, we saw an improvement for the total SPRS score after 12 weeks and 26 weeks. And why is it that way? Because we have differences in the control group and non-control group. If you look here at the total scores, you see that those graphs are cutting or overlapping. We did check for if there's if the group allocation or the time has an influence, but they have no statistical significance, so we can actually say that those treatments effect are real. And when you look at the absolute change of the SPRS score, that makes it a little bit easier to find out that it's actually an effect that is real. There's especially after 12 weeks, and there's at 12 and at 26 weeks a statistical significant difference. And when patients ask us how big is that difference, the difference picks up after 6 weeks of training, or 12 weeks of training, I mean, the difference is as large as what the regular decrease in SPRS points is within a year. So we can tell the patient that a 12-week training program is as like stops or improves you as much as you usually decrease within a year. So it's worth doing physiotherapy, because with our program you basically can halt or stop your disease progression that you have usually within a year. So and we also looked at our secondary outcome measures, the goal attainment scale, which also significantly improved for 12 and 26 weeks. And we had deterioration in the control group at the same time, so that physiotherapy has a personal, meaningful outcome for the therapy group. And when looking at the 3-minute walk, there was no difference. The most important points for us back then was outreach. So when you do a study like that, you want your patients to be available to include that in their daily routines. So what Rebecca did was publish all those 26 exercises as a resource for physiotherapists wherever they are based in Germany, to be able to access them and then use them, including our protocol, with their patients to improve their disease. As I said before, there are 2 ongoing studies for physiotherapy. Currently, the one is based in 2 locations in Italy. They are planning on including 20 patients with 10 to 16 sessions of 60 to 120 minutes each. And they started on the day before Christmas in 2024, and they plan to be done at the end of this year. And they have like 3 time points they're looking at: before the training, immediately after, and one after 3 months. And then there's another study, the walk-up study, which started by Alexandra Dürr's group and is led by Pauline Lelmont-Dudek in Paris, and was based on the MODIF SPA and MODIF SPA2 study. And the second one is a very, very nice thesis written in French, which I translated thanks to AI and read through it. And that is basically a questionnaire which was addressed to patients, what they, what kind of changes they feel by themselves, or what they think is important for them to be able to improve. So it is like a more patients-based study, or a more patient-based outcome, or started from patients-based reported outcomes, and is also planned to be done by October of this year. And they do a 6-week training program, and their main outcome measure will be walking speed. So at the end of this year, whenever those other 2 studies are done, we could say everything is solved, right? But there's one thing I would like to point out too, and that's something that patients mention a lot when you do a specialty clinic, is that you need to control for so many things if you do clinical studies. And one thing I really want to point out here is controlling for temperature as an influencing factor. There's a study, quite a nicely done study in a small group of patients of 22, which cooled the legs of controls and HSP patients, and they looked at the walking speed. And if you do your studies, I think we need to check for like outside temperatures. We need to be sure that we do it maybe on the same time of the year. We need to be sure that patients like warm up or stay long enough inside at certain temperatures to have at the end comparable measurements. And if I remember, for example, as one of the Kritikpunkte I would also address for us in Tübingen is where the patients did the 3-minute walk test was in the basement of the university hospital, and there it's a lot colder than in our examination rooms. So it could be one of the reasons why the 3-minute walk or the 6-minute walk is not significant, but I don't know yet. So at the end, and I'm before the time, that's quite good. I would like to thank Rebecca and also Mathis, who planned that physiotherapy study, and Ludger, who accompanied me for 14 years now in the HSP field, and the study team in Tübingen, and especially also the physiotherapist named Marion and Susanne, and all the patients participating in lots of our studies. And I have the pleasure or the special situation right now that I'm actually living in Kiel, and I'm 800 kilometers north of Tübingen, but I still have the chance to continue studies there. And I was this January back in Tübingen, and as you see, Tübingen has something that Recklinghausen does not have as well. Thank you.
Thank you, Tim. We will have at the end a discussion. So we move on and we go to the poster flash talk. Clara Metzner from Erlangen. She's a doctoral researcher and she's doing her PhD in neuroscience. And Clara will talk about high throughput phenotyping of fibroblast-derived induced neurons in SPG4.
Yes, thank you for the introduction, and also thank you to the organizers for the invitation to present my PhD project here today. Okay. Doesn't matter, it's fine. Yeah, I will be talking about a high throughput phenotyping of fibroblast-derived induced neurons in SPG4 HSP. SPG4 HSP, as you know, is a rare disease, a rare motor neuron disorder, which is genetically defined by pathogenic variants in the gene Spast, which encodes the protein spastin. And the role of spastin in the cell as a microtubule severing enzyme is the regulation of microtubule dynamics. Also, due to its close proximity to the endoplasmic reticulum, it also has roles in axonal transport, synapse formation, and also remodeling of the axonal ER. Now, what are functional consequences of an impaired microtubule remodeling in SPG4? And to study this, a lot of studies in the last years have used iPS-based models. iPSCs are generated from patient fibroblasts. Due to reprogramming, they are generated iPSCs, induced pluripotent stem cells, and those can be redifferentiated into neuronal cells. And in all these models, a lot of axonal defect phenotypes have been investigated. For example, neurite swellings have been seen, usually driven through an accumulation of organelles like lysosomes or mitochondria. This has been shown in mouse models and iPS models by us and also other groups, which goes along with axonal transport deficits. So those organelles, if they are stuck in swellings, they are also eventually not transported very well. And lastly, it has been seen that neurite length and complexity are reduced in SPG4 neuronal models. However, iPSC neuronal models also have their drawbacks. They show limited scalability. They are time-consuming due to the reprogramming step, which can take up to half a year. And they also represent a rather early developmental stage. So that's why I want to introduce you to this model, which are the so-called fibroblast-derived induced neurons. We call them FINs. And they enable to have bigger cohorts, so to include more pathogenic variants. The protocol is short, easy, and most importantly, the age-dependent transcriptomic signatures are retained. So epigenetically, they are rather older than iPSC-derived neurons. So specifically how we generate them in the lab, we do this by transducing fibroblasts with this lentiviral construct that you see here, which encodes a doxycycline-inducible system for the overexpression of NGN2 and ASCL1, two neuronal transcription factors. And after selection, we get the so-called UNA or UNA fibroblasts, which harbor this construct and stably express it. And upon induction with doxycycline, we can then, within 21 days, get the fibroblast-derived induced neurons. We also add small molecules, morphogens, to that media. So after 3 weeks only, we can get mature neurons in a way. We analyze them by immunostaining, so we stain for neuronal markers, NU-N, beta-3 tubulin, and also MAP2, and we see a significantly higher expression in the neurons below compared to the fibroblasts. We also analyze this with RNA sequencing data, and we see that the fibroblasts here in blue and the neurons, they are transcriptionally very different. So the PC1 value is almost 90%, and so the cell type itself is the major driver of the variance in this data set, which we also see when we look at the number of differentially expressed genes. So more than 6,000 genes are differentially expressed when we compare neurons and fibroblasts. If we look at the upregulated genes in the neurons, we see that a lot of those are neuron and synapse-associated terms, which concludes that we can say that our differentiation is successful and we really get neuronal culture in the end. So we wanted to move on and do some phenotyping with these cells. So we started with a cohort of 7 control fibroblasts and 5 SPG4 fibroblast lines with different pathogenic variants. We generated fins and seeded them using our automated pipetting system on 384 well plates, so we could get as much conditions as possible. And then we also stressed the cells with sodium arsenide for oxidative stress and thapsigargin for endoplasmic reticulum stress. We fixed the cells and performed cell death assay and immunostaining, and then did high throughput microscopic analysis for image analysis. So in the end, from one image, we were able to generate or to output 6 phenotypes in the end. If we look at those cultures, the first thing we noticed is that these cultures are rather mixed. So they are not 100% pure neuronal culture. If we quantify this by the percentage of NU-N positive cells, we get something like 30% NU-N positive neurons, which is not significantly different between control and SPG4. So the differentiation works well independent of the genetic background. But this led us to the possibility that we need an automated pipeline for neurite segregation. So we really only want to analyze the NU-N positive cells. Going into that pipeline, I want to show you how we did this. So we did this with Cell Profiler, which is an open access image analysis tool. We started by identifying the nuclei from the DAPI image, as you see here. Then we moved on to the NU-N positive nuclei, which we did by masking the NU-N positive signal onto the DAPI signal that we generated before. And then from these NU-N positive nuclei, we used the propagation tool to then reconstruct a rather ideal neuronal network for each image, for each condition. And from this neuronal network skeleton, we were then able to analyze parameters like skeletal length, also intensity parameters, and complexity. And for the sake of time, I will now only show those that were significantly different between control and SPG4 neurons, which were neurite length and neurite disintegration. Neurite length was significantly decreased in our SPG4 neurons, which has also been shown before in IPS neurons. And coming to the neurite disintegration, the concept is that destabilized microtubules, like in swellings or in damaged neurites, that they occupy higher beta-3 tubulin intensity values. And I think you see this here on the right. As a proof of concept, we stressed the cells with sodium arsenide, and you see here these fragmented microtubules. So you see these little dots, which are actually fragmented beta-3 tubulin values here. And if we compare this in the non-treated condition between control and SPG4 neurons, we see that the disintegration index, or the area ratio of the disintegrated microtubules, is significantly higher in SPG4 than in control neurons. To conclude, we established this protocol to differentiate fibroblasts directly into neuronal cells, which we proved by immunostaining and also by RNA-seq. And this platform is a valuable tool in our eyes for automated image-based phenotyping of any age-related disease. And in our SPG4 use case, we could show several signs of neurite damage, specifically reduced neurite length, which has been shown before, and now also an elevation of the neurite disintegration index. And maybe to look where this could go is that this platform also supports high-throughput drug screening, so we can test a lot of conditions, a lot of drugs in literally any age-related disease where you could see a degenerative axonal phenotype. So I want to thank you for your attention. I also want to thank my supervisors for their continued support, and I would be happy to take questions now, or you can also find me at my poster later. Thank you.
Okay. We will have questions at the end of the section. And now I invite the last speaker for poster flash talk, Ingrid Kohlen from Heidelberg. Ingrid is a PhD student in Rebecca Schule Laboratory, and she will present personalized ASO therapy for ALS associated with KIF5A mutations around exon 27, multi-strategy approach. Good.
Thank you for the kind introduction, and thank you for the organizing for inviting me here. So I'm indeed working on a personalized ASO therapy for ALS-associated KIF5A mutations around exon 27. I use different strategies for this. This is an ongoing PhD project, so it's not finished yet. So ALS, also called amyotrophic lateral sclerosis, is a neurodegenerative disease where both upper and lower motor neurons degenerate, instead of HSP, where only the upper motor neurons degenerate. Most causes are idiopathic, but for some, genes have been found which cause this disease, such as SOD1, TDP43, and more recently, KIF5A. KIF5A is also known as a HSP gene, but more recently, they also found that it also can cause ALS. So KIF5A is one of the heavy chains of the kinesin 1, which transports vesicles and mitochondria over the microtubulus. And interestingly, for all of the ALS mutations, is that they cluster around exon 27. So if you can see here that these are, by the way, heterozygous autosomal dominant mutations. You can see in blue the exon 27 skipping mutations, and in red the frame shift mutations. So for HSP, the mutations are more in the motor domain or the stalk domain, so on the other side of the protein, and this is on the end of the protein. These mutations all cause the same novel toxic C-terminus. So for the wild type, you can see that exon 26, 27, and 28 are coding, and exon 29 is a non-coding last exon. For the exon 27 skipping mutation, you skip exon 27, you get a frame shift in exon 28, and also a part of exon 29 becomes coding. Similarly, for the frame shift mutations, you only have the frame shift earlier already in exon 27 or exon 26. This protein is also expressed, and it's toxic. So you can see here the pathophysiology. So the first you have on the top the healthy control situation. They have 2 times the wild type protein, and this protein forms
it folds into itself into an auto-inhibited state. So the majority of this is normally in an auto-inhibited state, and part of it is in the active state and transporting over the microtubulus. For the KIF5A-associated ALS patients, they have one wild-type protein and one toxic protein, and this toxic protein causes aggregation of not only the toxic protein itself, but also part of the wild-type protein is in these aggregates, and it also causes that the protein cannot auto-inhibit itself anymore, and therefore becomes always active. So it's disturbing the distributions of the mitochondria and synaptic vesicles in the neurons. So our aim is to prevent this expression of this toxic C-terminus, and we want to do that with ASOs. So we have two different strategies. We have strategy 1, where we want to prevent exon 27 skipping and restore wild-type splicing. And here we want to have an ASO which targets efficient intronic splice sinusocytes. The second strategy is to induce exon 28 skipping to shorten this toxic C-terminus, but this will result in a truncated protein. Previous studies have showed that this truncated protein is still functioning partly, but we'll see. We also want to do this with an ASO, and the ASO will target efficient exonic splice enhancer sites. So we go first with strategy 1, which is exon 27 retention, where we want to prevent exon 27 skipping and restore wild-type splicing. So the big question is always where to target our ASOs, where are our splice regulatory elements that cause this exon skipping, and which one can we target to prevent this. So you can either do this with predictions, with algorithms, but they are not that reliable. So we chose for a more experimental approach and to do a mini-gene. So a mini-gene, in short, is just you take a small part of the gene, you put it into a plasmid, and you express it in a simple cell model, such as HEK cells, and check the splicing outcome on RNA level. So the steps will be to establish first a mini-gene and then make deletions to see where are these regulatory sites. So that's what we did. So you can see here a little bit of our mini-gene. We transfected it in HEK cells, and we will see the effects of the splicing. Since we have mutations on both sides of the exon, also in the exon, there might be a different splice regulatory element that causes this skipping for each of these mutations. So that's why we decided to do 5 mutations in our constructs instead of just using one mutation construct. We made 5 different ones, and we want to see where, which ASOs will work for all of them, ideally. So we made deletions in our mini-genes. So you can see here the deletions, they cover a region of around 200 bases, where we have 5 deletions in intron 26 and 5 deletions in intron 27. And we finally get to the results. So here we see just the first results of establishing the mini-gene. So you see the wild type has the middle band. Can I show? You see my mouse? The wild type has a middle band, that's the wild type transcript band, which should be there. We also already see a lower band, that's the exon 27 skipping band, which shows that our mini-gene is not fully representing the situation that normally happens in the neurons. And we have an upper band, which is the heteroduplex band, where you have both the wild type and the exon 27 skipping transcript. For the mutation 1 to 5, we see mostly the exon 27 skipping band, what is expected, because they are mutations that skip exon 27. But also for mutation 1 to 3, we have this heteroduplex, which means that we still have some wild type available. If we now make deletions in all of these constructs, we see some results here for the deletions. These are the most promising deletions. So for deletion 1, you can see that for mutation 1 and 3, this upper band, this heteroduplex, becomes more intense, which means that more of the wild-type transcript is available. For mutation 2, we even see recovery of the wild-type transcript band. If you go to deletion 10, we have even more promising results here. For mutation 1 and 3, the intensity of this heteroduplex is even more intense, so we have even more recovery of the wild-type transcript. And for mutation 2, we have full recovery of the wild-type transcript, and we don't have any of the exon skipping transcript anymore.
So the next steps would be to do an ASO walkover over these candidate regions to see which of these ASOs also show the same results as the deletions, and evaluate these ASOs not only in a media gene, but also as in a patient neuronal model. Let's go to the other strategy we have. We have the exon 28 skipping, where we want to induce exon 28 skipping to shorten this toxic C-terminus. And since exon skipping ASOs are more commonly done, there are quite good guidelines for this. So we decided to just use the guidelines, use predictions here, and design ASOs based on that. So you see here 4 ASOs that we designed that we transfected in a wild-type neuronal cell model. And you can see for all of the 4 ASOs that we have some exon 28 skipping, which the ASO 4, roughly 60% skipping if we quantify it with the gel. So the next steps for this strategy is to evaluate the exon 28 skipping on protein level, and also evaluate this, of course, in a patient neuronal model. So if all of this works, we have 2 strategies to prevent the formation of a toxic C-terminus, and hopefully a treatment option for the ALS patients with the KIF5A mutations. And with that, I would like to thank my PI, Rebecca Schule, and our lab, and also all our collaborators and funding agency, and again, the foundation for inviting me. Thank you.
Thank you. Please, Guido, Kim, Clara, come to the stage. We have a final common discussion, I think. I give you the mic, so Guido is coming. Are there questions? Okay, 1 second. Just go to the, wait.
I have a question for Ingrid. If your strategy works, what will be the phenotype of the patient treated by this ISO?
So that depends on the strategies. The first strategy is to prevent exon 27 skipping. So then you restore wild-type splicing. So hopefully with the ASO, if it works 100%, you have a healthy person. For strategy 2, it's induces exon skipping, so you get truncated protein. We're not sure what the phenotype will be for that one, because it will also skip exon 28 for the wild-type allele. So it depends on how well functioning both of these proteins will be.
So congratulations to you all. These were very interesting talks. I have a question to Tim, actually. You're probably not surprised. So have you considered using things like posturography or gait right assessments? We've done a similar study looking at physical therapy in Huntington's disease that we published a couple of years ago, and they were actually quite good quantitative markers. Have you considered using that at all? It may be more precise than some of the assessments you've considered.
If I would do this study now again, I would actually use those things, but at the end, when we did it back then, we had data from our functional electric stimulation study on gait analysis and so on, and the data was so heterogeneous, because HSP is so heterogeneous. If you think about spastic ataxia as one of the phenotypes, that postural things, depending on if you include cerebellar phenotypes or not, can be very, very difficult. And since one of the inclusion criteria was just clinical HSP, not even genetic based, that was one of the reasons why we didn't want to use it. I think even then, as clinicians, we would always say, let's go for SPG4, but looking at all the data from yesterday with the heterogeneous phenotype, even in SPG4, I don't think it's so easy. And then you need to base them on clinical inclusion and so on, and that makes it really, really hard.
Also a question for Tim, and congrats for the work. As far as I got, like at the end, you have like a difference of 3 points in SPRS from the 2 groups. And this is a huge difference if you consider like the natural history of the condition, right? So do you have any clues like anchoring with PGI or something, if this was really meaningful to patients? Like, can you have any idea about like a threshold of meaningfulness based on this symptomatic effect?
Since we have the goal attainment scale in there, which is a meaningful outcome measure for the patients, because they define their
outcomes by themselves. I think that's probably the best thing to anchor them to meaningfulness, at least when we look back at the study. But as we discussed in all those other meetings with meaningfulness, I think this discussion came too late for that study, to be honest.
Hi, Leonardo Bocconi, the PI of the ongoing FRAME trial. So thank you for referencing on that. I have a question which is related to therapy. When the patient finish the interventional trial, we go home and we visit a follow-up, how you are suggesting patient to keep going with the exercise at home, or if you provide any tool like a manual or some video tutorials or something. I'm curious about the long-term maintenance of the gains.
I think I had a QR code in the publication, which is a website, and on those websites are tutorials for all those 26 exercises in there. So what we basically teach the patients now, and we also do that in the outpatient clinic with like links, which we refer to. We say, please use this resource to teach your home-based physiotherapist to tailor your program to include that into your exercises. But I think the other thing what we need to think of as well is that motivation is something that's really, really strong bias or strong influencer in that studies. And I think if I would need to redo such a study, I would think of diaries and ask them what they do besides the training parts and how often they do that, because I think that's probably one of the hardest confluencers. In a study, people are a lot more motivated when they are in a study than after they return into their routines. So I think that's something that we need to think of as clinicians as well. That's probably one of the big factors. If you come back home and you're not in a study any longer, do you still continue with your trainings?
Yeah, Gerald Fischer. I have a question to Dr. Goy. Congratulations to this wonderful work. So you were investigating a condition which is comparable to a relatively fast progressing HSP. It seems with the combination therapy you were able to slow down the progress but not to stop the progress. What does this mean for the acceptance of the patients? Because they still have the feeling that they are progressing. Do they also have the progression that your therapy helps them, and that are they showing a compliance to your therapy?
Yes, until now the compliance of the patients was 100%, you can say. You're the first ones to listen to this results, so actually the members of our patient group and the parents still do not know what we have found out. I think I will contact them next week, and I had already an email by one patient's mother who wants to have miglustat approval by the health insurance, but she has written, I think, the third contradiction, and has not yet been permitted. And she was asking me now for the results of our study, and maybe I can now go into open with it and try to help her, support her to get the permission for the miglustat treatment. I don't know what it will be like concerning the fingolimod treatment if we tell the parents that just the combination of fingolimod and miglustat was a game changer. But as most of them profited in so far that the neurobehavioral features were improving, and this was really significant from the point of view of the parents. I'm quite hopeful that they will continue with both treatments. And well, our next step will be to increase the just miglustat treatment group, just to find out if there's a synergistic effect of miglustat and fingolimod in the CLN3 patients. And I know that the Professor Martini group has also done tests on certain genotypes of SPG, I think it was 11 and 48, showing that there was a motor improvement in these mice, especially concerning, or at least concerning the strength-related features, not so much ataxia. And so I don't know if Janos Groh is here today, but I know that he's attending the conference, and well, we will also contact the study group and try to find out how we can go on.
Additional questions? I have one for the two poster talker. One is for Clara. Are you working on some specific protocols to increase the ratio on neuronal cells just to go over the, let's say, the threshold of 50%? Just
yeah,
that's
a good point. I think that's the big drawback of this protocol, that it's so impure. We have tried sorting, so on like these magnetic bead columns, we have tried this, but it didn't significantly improve it, and then it wasn't worth the loss of material. And since for our case now, we mainly do the phenotyping, so we mainly want to look at images, and for this we have the pipelines that it works, even if the culture is not so pure.
And the outcome differs depending on the mutations you have?
No, it's not dependent on genetics. It's rather how you do the transduction, how efficient the transduction was in the first place.
And the last question is for Ingrid, just to check whether, I mean, just to go translational, did you try to explore other SPG-related genes or other mutations associated with KIF5A, for example, for SPG10, not related to ALS, but potentially treatable in the same way? Just to go over the ALS and move again back to HSP.
So I haven't personally not done that yet. I thought that the KIF5A, the HSP mutations are mostly missense mutations and not that many splice variants, so it might be difficult to have an ASO that targets or changes the splicing. For HSP10, I don't know.
Okay, no other questions? I think we have to thank all the speakers. Go to lunch. The poster section, when are we supposed to be back? 1:30?
10 minutes before 2.
Okay, we are back. Oh.
Okay, sorry. Yeah, just a quick note again, please enjoy the lunchtime, and please also walk through the poster exhibition and listen to the presenters, and then choose your 3 best posters with the QR codes. And we will meet at 1:50. Thank you.
Non, mais c'est bon, c'est... Ouais.
Il est, c'est bon. Comment on fait pour...
So I think we will restart a little bit earlier than, I think we had 2 or 3 minutes before the time, but so we will close the scoring for the poster prizes at 2 o'clock. So if someone needs to score, he should do it now or never. So for the session 8, treatable HSP forms, it's my pleasure to introduce Gaëtan Lesca from Lyon, who is a medical geneticist and will talk about the coenzyme Co9 associated form of HSP.
Thanks a lot. So I'm really pleased to be here with you, and I realized when I'm here that my first important paper in my life was made on spastic paraplegia. It was a collaboration with Filippo Maria a long time ago, but it was a very interesting study. So now I'm back with another study, but it's not a large cohort of patients. It's only about one family of an ultra-rare disorder. So this is about a form of hereditary spastic paraplegia linked to COC9 deficiency. So COC9 is one of the proteins who belongs to this complex, which is needed for biosynthetic of coenzyme Q. It is the last protein involved in this complex, and it has a role in stabilization of COC7. That's the main role. And COC7 is involved in the last step of the biosynthesis of coenzyme Q. This disorder is very rare, disorder related to COC9 mutations. Only a few publications that are summarized on this table. And you can see that the child were affected very early at birth, and actually even before birth, because there were some prenatal signs in every child with some decreased fetal movements, oligodramnios, cardiac involvement. All children were severely affected by multi-organ failure at birth, and most of them died very early. And these children, some of them pregnancy were terminated because it was the second child of a family with the first affected child. And the mutation in this family were mostly a truncated mutation or in-frame deletion. So that was the situation for this disorder. Now, we have a family in Lyon that have been followed since 2012 to make a diagnosis, including one boy and one girl. They are from various origins, and especially a Yenish origin, and the parents are first cousins. In this family, the brother, which is now 24 years old, had walked at 16 months with frequent falls and needing a medical device to walk since the age of 3. At last examination, which was this year, he has a symmetrical motor deficit in lower limbs, no deficit in upper limbs. He has a severe pyramidal syndrome, no other organ involvement, and has no cognitive impairment. He's working on a computer at home, and brain MRI, when it was done, was normal. The sister has the same disease course. She's now 21. She worked at 4 years with, she started to work with the medical device. Now, none of them can walk anymore. She has the same symmetrical motor deficit in lower limbs, but she has also a mild deficit in the upper limbs. And they are stable. Over the years, they are stable. No improvement, of course, but no degradation, no obvious degradation over the last years. So we started with metabolic screening a lot of years ago, then targeted genetic screening, gene panels, etc. And at the end, we performed exome sequencing in this family to find the cause of the disease. We had one interesting finding in exome sequencing in this family was a missense variant of COC9. This variant is a missense But as you can see, I don't know if you can see, the prediction for the missense are not very, very good, except for the CAD-FRED score, which is related not to the missense, but to an effect on splicing, because this variant is located on the last nucleotide of exon 1. The patients were homozygous and the parents heterozygous, and this variant is very rare in the control population. It is present 3 times at the heterozygous state in GNOMAD and absent in all of us. So, of course, the phenotype is completely diverse from what is published for COC9, but because of the predicted effect on splicing, and because we know that this kind of disorder can have a very variable course, we wanted to go on to see if we could have some evidence of the involvement of this mutation in this family. So there are some rather good predictions for splicing. This is the splice-I prediction that show that this is the normal case, and in the patients, this splice site is weakened, and there is another one in the middle of the exon that is activated. So this is one prediction, but it cannot predict everything, as we will see later. And there is another prediction by another software, which is PEEP, which is very, very high. So according to that, we wanted to go on in our lab and in collaboration with other groups. So what we did, we performed some samples from the patient, fibroblasts, lymphoblasts for both, and muscle biopsy for the boy. And we first studied the transcript. This part of the study was made a few years ago, so it's not RNA-seq. Today it would be this, but it was RT-qPCR. And normally, we have one transcript which is here in the controls, and in the patients we have a different transcript. That the normal one is here. It is decreased in these cells. It is not really decreased in the myoblast, but we also have some abnormal transcripts. This is not a quantitative study, so we don't really know the normal population. So we perform some relative quantitative analysis, and we see that the normal transcript is decreased, not completely absent, but it's highly decreased. And we also perform some Western blotting, and the protein expression is very, very low, probably not completely absent, but very low. And we then, in collaboration with the group of Stéphane Allouche in Caen, we wanted to go to study the effect on coenzyme Q metabolism on the respiratory chain, and we performed this dosage of coenzyme Q in muscle, plasma, and fibroblasts of the patients. And coenzyme Q10 was reduced in the muscle of the patient, of the boy, and it was reduced in the fibroblasts of both sibs. And in addition, there was an accumulation of 6-DMQ in fibroblasts due to the destabilization of coenzyme Q7 by the absence of coenzyme Q9. Then we studied also the mitochondrial metabolism, the respiratory chain metabolism, and as expected in that case, because of the deficiency, secondary deficiency in COX7, we observed a reduction of activity in the coenzyme Q10 dependent complexes. It means 1+3 and 2+3. At the end, we studied the effect on the variant on culture fibroblasts. This is a negative control. This is a control with a COX7 deficiency that we published in another paper. And these are the 2 patients from this family. And when the fibroblasts are cultured with glucose, it's quite okay. When we use galactose, it's challenging the respiratory chain in the 3 patients with COX9 deficiency and COX7 deficiency. And when we add coenzyme Q10, it is restored. So what we did is to propose to the family to take ubiquinone. High doses were required for that. They took the treatment for 3 years with no objective effect. It means that we don't really know if it was an effect, a stabilization effect, or if it didn't do anything. We don't really know. But unfortunately, they decided to stop, to discontinue the treatment mainly because of intestinal problems, because they had to take many, many pills every day. And for the sister, she also had hyperthyroidism, and the endocrinologist said it could be related to the excipient of the treatment. So in conclusion, this is an unusual presentation of COX-9 deficiency with a spastic paraparesis that is probably slowly extending to the upper lips in the sister, but we don't really know if it's recent or if it's something that happened a few years ago already, with no additional involvement due to this missense variant that has many effects on splicing. How can we explain this high variability between this family and the other children published previously? Maybe because of the remaining coenzyme Q9 protein, we don't really know. And of course, it's difficult to appreciate the effect of ubiquinone in these patients because we need more years, and we only have one family. We don't have any comparison to do that. So this was published in a European Journal of Human Genetics in 2025, and it's collaboration between our group in Lyon and the group of Stéphane Alouche in Caen. Thank you very much.
Thank you. I think we will keep the questions after the next talk, and the next talk is also an QNCQ related disorder, and will be presented by Felix Distelmeier, who is the head of the Children's University Hospital in Düsseldorf. Düsseldorf is not the Ruhrgebiet, but the Rhineland, but it's very close to the Ruhrgebiet. So thank you for coming to Recklinghausen.
Yeah, many thanks for the introduction and many thanks for the invitation here to Recklinghausen. Yeah, so I will continue with a topic on CoQ10 deficiency disorders, and I'm happy to present a novel treatment for one specific subform which is caused by defects in CoQ2. Just briefly, my conflicts of interest. Well, you have heard a bit about CoQ10 in the previous talk, so I will try to keep this relatively short. I think from this slide it's important to visualize how large and complex the CoQ10 molecule is, and this has important implications for treatment, and I will come to that later. It's also important to keep in mind that we are not dependent on external CoQ10 supply. So CoQ10 is provided by an indigenous biosynthesis pathway, and for the function of this pathway, at least 14 different enzymes are required. And to date, we know that in 11 of the corresponding genes, disease-causing variants can occur, leading to variable clinical phenotypes. Well, as I've indicated on the previous slide, the standard of care for CoQ10 deficiency disorders is oral CoQ10 supplementation. However, this is ineffective in most of the patients, and that is because CoQ10 is so large and is also highly lipophilic, and therefore the bioavailability is low, and especially the uptake into different organ systems is a problem, specifically the central nervous system. And many of the CoQ10 deficiency disorders present with neurological features. The other thing is that we don't know how much of the external supplied CoQ10 is actually ending up in mitochondria and really participating in mitochondrial energy production, and that could also be a problem with the lack in treatment response for many of the affected individuals. Well, if we look in detail to the CoQ10 biosynthesis pathway, the entry point of this pathway is actually constituted by the CoQ2 enzyme. And the CoQ2 enzyme facilitates the fusion of the head group, so labeled here in blue, with the long side chain labeled here in red. And all further enzymatic modifications of the molecule are carried out at the ring structure, so not at the tail group. Pathogenic variants in CoQ2 are known for more than 20 years now, so quite some patients have been described in the literature. And we know that there are different clinical phenotypes associated with these genetic variants. So on the one hand, there is one very early prenatal or neonatal manifestation with severe lactic acidosis, multiple organ involvement, rapid progression, and a very poor prognosis. So many of these children die already during the neonatal period. Then there is something like an intermediate phenotype that manifests in infancy or childhood. These children have neurological features like ataxia, muscular hypotonia. They can have neurological regression, and quite typically they have associated steroid-resistant nephrotic syndrome, which rapidly progresses to renal failure and is also important for the poor prognosis that this disorder has. And then we also know that there are juvenile or adult onset phenotypes. So for example, in the Asian population, there is a subtype of the multiple system atrophy associated with the CoQ2 gene, but there are also more or less isolated organ manifestations in older patients like progressive kidney failure or retinopathy. Well, based on the problems with the treatment effects of CoQ10, which are not as good as we would like to have them, our group in Düsseldorf is working for many years now on alternative treatment strategies. And one idea that we had was that we use small molecules that are derived from the head group. So this is just indicated here. So we use, for example, compounds which are depicted here on the slide, which only contain this ring structure with certain modifications, but lack the long side chain, which is important for the poor bioavailability. So these small molecules have much better biophysical properties in terms of treatment and tissue penetration. And the idea is that we use specific compounds that have modifications that can be, or that help to bypass specific enzymatic defects. So during our drug screening experiments, we also used cell lines of patients with CoQ2 deficiency. And during these drug screenings, we observed that the substance 4-hydroxybenzoic acid, which is depicted here on the left, is actually clearly improving the endogenous CoQ10 biosynthesis in these CoQ2 deficient cell lines. And that was quite surprising and also a bit puzzling to us because 4-hydroxybenzoic acid is the direct substrate of the CoQ2 enzyme. So normally if you have an enzyme deficiency, you would not expect that giving more of the substrate is solving the problem. So to understand this effect in more detail, we created an in silico model of the CoQ2 protein and did a substrate docking analysis, which is depicted here on the right. So what we are basically, what we have done is to look for binding sites of 4-hydroxybenzoic acid within the CoQ2 protein. And as you can see, there are different binding sites inside the protein which are located close to each other, so that we came up with a hypothesis that there's something like a transportation channel within the CoQ2 protein. And if we now model the known disease-causing variants on top of this model, you can see that these variants are clustering around this putative transport channel. So based on that, we had the idea that the transport of 4-hydroxybenzoic acid towards the catalytic site is hindered by the disease-causing variants. And quite strikingly, we never find patients with mutations that really affect the catalytic site. So that's not compatible with life, that's what we think. And when we, for example, investigate patient fibroblasts, we always see that the protein levels of CoQ2 are normal, so they're not reduced. So basically, the enzyme is there, but it cannot work at normal rate because it does not get sufficient substrate. Now, if we increase the 4-hydroxybenzoic acid concentrations, we can apparently overcome this problem. Well, at the time when we published this data, no in vivo model was available for CoQ2 deficiency, so it was difficult to go further also and to think about clinical applications. But this changed in 2024 when a mouse model was published by the group of Luis Lopez in Granada. And this CoQ2 mouse model has a human pathogenic variant and has a very severe phenotype with perinatal lethality. However, if the pregnant mouse is treated with 4-hydroxybenzoic acid, this phenotype can be rescued and the mouse can develop normally as long as it is treated with 4-hydroxybenzoic acid. This, the mouse is only doing fine as long as it gets the 4-hydroxybenzoic acid. So if you stop the treatment and give only CoQ10, as it is depicted here in this movie, you can see that this mouse rapidly develops a very severe phenotype and then also rapidly dies. So CoQ10 cannot rescue the phenotype of the mouse. This is also illustrated by this picture. So here with the blue labeling, actually you have the healthy mouse with normal CoQ2, then with the green labeling is the CoQ2 deficient mouse that is on CoQ10 treatment, and with the orange label is a CoQ2 deficient mouse that is on 4-hydroxybenzoic acid treatment. So you can clearly see that the 4-hydroxybenzoic acid treated mouse is doing very fine. So based on this preclinical data, we again came back to the idea that it is maybe worthwhile to try treatment of affected individuals with 4-hydroxybenzoic acid. But the problem is that 4-hydroxybenzoic acid is not available as a drug or as a food supplement. So you can only buy it from the chemical industry, and then it comes like that. And you can already see that it's labeled as a dangerous substance. So when we first went to our pharmacy to discuss if we can treat a patient, they said that this is potentially harmful and we should not do that. So what we did is that we went into more details of what is known about 4-hydroxybenzoic acid. And the interesting thing is that the dangerous labeling is because of the acidity. And if you look at the degree of acidity, which is clearly indicated for the product, it's the same as for aspirin or vitamin C. So it looks more dangerous than it is. The other thing is that 4-hydroxybenzoic acid already has a GRAS label from the FDA, which means generally regarded as safe. And that is based on the fact that 4-hydroxybenzoic acid is a very important precursor of parabens, which are present, for example, in cosmetics and other products that are at least in human contact. So in fact, 4-hydroxybenzoic acid is all around us, but of course we are not taking it in high doses. But based on this FDA labeling, there has been extensive toxicity studies done in animal models. So considering these two aspects, we could think, okay, then maybe it's not so dangerous to give this to a patient, but still this is not produced in a GMP-conform manner. And to produce it for a named patient use in a GMP-conform manner would be too expensive, but there are companies that provide GMP-like purity testing. And the nice thing is that you can buy 4-hydroxybenzoic acid at high purity for very less money, so 1 kilogram costs about 25 euros. And then you can do additional purity testing of such a batch, which is a bit more expensive, but in the end you end up with a lot of material that you could theoretically use for patient treatment. The next step in our case was then ethical counseling to have further approval for, let's say, our planned treatment. And finally, we got these capsules for compassionate use from our hospital pharmacy. The next thing was to select a patient where we could offer this treatment to, and in our situation that was a 3-year-old boy that was treated at our hospital at the time with an intermediate phenotype of CoQ2 deficiency. So he had global developmental delay, muscular hypertonia, ataxia, failure to thrive. He had brain MRI abnormalities, and he also had a steroid-resistant nephrotic syndrome, which was progressing. And this is actually a video of this boy at the age of 3 years. And as you can see, he is not able to walk independently. He's also quite small for his age. He only speaks a few single words. And he was already on CoQ10 treatment for about half a year and did not respond, especially the kidney function was deteriorating. And therefore, we discussed with the family if we should try 4-hydroxybenzoic acid. And well, they agreed to the treatment, and then we extrapolated the dose from the mouse model, started at a low dose, and then continuously increased, and it was well tolerated, so no obvious side effects. And this is a video of the boy after 3 months of treatment, and you can see that during that time he gained free walking abilities, he gained muscle strength, ataxia was less, and also speech development progressed rapidly. The episodic vomiting, which was a big problem for him, subsided. So in many aspects he responded clinically to the treatment. The good thing about CoQ2 deficiency is that you can monitor quite some biomarkers. So for example, on the upper left, you can see that the lactate levels dropped with treatment quite rapidly. Then in the upper middle panel, you can see that the CoQ10 levels in serum continuously increased. And it's important to note that we stopped CoQ10 treatment at the time when we started with 4-hydroxybenzoic acid. In the middle row, in the left and the middle panel, you can see the albumin and the protein loss in urine, and that was quite striking. That normalized within 2 to 3 weeks after onset of treatment, so kidney function dramatically improved in a very short time. And in the lower two panels, you can see the increase in body weight and also the clear improvement in the Newcastle Pediatric Mitochondrial Disease Scale after 6 months. So this boy is now for 1.5 years on 4-hydroxybenzoic acid treatment, and he has no side effects so far. He's continuously improving from his neurological functions, and kidney function is continuously stable, so never deteriorated. He never had metabolic crisis or anything. So that's quite promising, but of course it's just a single case and many questions remain unanswered. And one of the important questions is if also the very severe neonatal onset phenotype can respond to this treatment. And to address this question, there was actually a coincidence that helped us to understand that. And these are actually clinical images of a child that was born around 3 years ago in a hospital in Stuttgart. And I was involved in the case because the child presented with severe lactic acidosis directly after birth and also multiple organ failure. And mitochondrial disease was suspected. And then we recommended empirical cofactor treatment, also high-dose CoQ10. And despite the treatment, this child rapidly deteriorated. You can see on the right the brain MRI at the age of 2 months already showing global brain atrophy. And this child then died at the age of 2.5 months in a palliative care setting. And despite rapid genetic testing, which revealed CoQ2 deficiency in this case and also a high-dose CoQ10 treatment, this clinical course could not be prevented. So the coincidence was now that just when our first treatment study was published in summer last year, I was recontacted by the doctors from Stuttgart, and they said that the mother of this child just presented to their gynecology department and she was pregnant again and birth was imminent, and no prenatal testing had been done. So it was unclear if this child also had CoQ2 deficiency. But during prenatal ultrasound, oligohydramnios was noted, and this can be a sign of a prenatal manifestation of CoQ2 deficiency. So we discussed how to proceed in this situation, and we decided with the doctors from Stuttgart that we would start empirical CoQ10 directly after birth, and that we would do rapid genetic testing, and in case that the child has a clear disease manifestation, 4-hydroxybenzoic acid could be an option, and we shipped the substance to Stuttgart and also discussed that with the family, of course. And this is now the clinical course of this second child. And as you can see in the graph on the lower left, this child developed severe lactic acidosis within 7 to 8 hours after birth, up to 14 millimole per liter, so severe lactic acidosis, then kidney failure, encephalopathy, multiple organ involvement, so a very comparable course to the siblings. So it was very likely that this is also CoQ2 deficiency. And this happened despite CoQ10 treatment. So therefore, on the second day of life, we decided to start with 4-hydroxybenzoic acid treatment, which is depicted here in green. And as you can see in the lower panel, the lactate levels dropped quite rapidly and normalized. And also the kidney function, which is indicated in the 2 upper panels, normalized within 1.5 to 2 weeks. And also very pronounced, the respiratory problems, the encephalopathy resolved very quickly. And I think the clinical course is nicely depicted by the clinical photographs, which are depicted below, which were taken at comparable time points. So this child was doing much better, and also the MRI, which is depicted on the right, at the age of 2 months didn't show any signs of brain atrophy. So this child is now under treatment for 6 months and is developing neurological normal and has also no kidney problems anymore, so a very striking and also maintained effect of the 4-hydroxybenzoic acid treatment. So based on these 2 cases, we are relatively confident that 4-hydroxybenzoic acid treatment is a very good option for CoQ2 deficiency. Still, maybe one question remains in how far these effects could be mutation-specific or variant-specific. Are there maybe CoQ2 patients that do not respond to this type of treatment? And on the upper right, you see again the graph with the CoQ2 model and the mutation. So based on that, we would say that all the variants that we modeled should have more or less the same effect. So they should all hinder substrate transport, but they should not affect the catalytic side of the enzyme. And which is indicated below is that we tested already quite some fibroblast lines from CoQ2 deficient patients with different variants, and in all of these fibroblast lines we saw a very clear recovery of the endogenous CoQ10 biosynthesis. So for all the variants that we modeled or investigated in vitro, we have the same effect, so therefore we are confident that at least the majority of patients should respond to treatment. So currently, 4-hydroxybenzoic acid has an orphan drug designation for CoQ2 deficiency from the EMA, and with the team from Spain, with Luis Lopez, we are currently trying to organize a clinical trial as the next step. So finally, I would like to thank all the people that were involved in this project, so especially the team from Spain, Luis Lopez and Julia Corral, who did the mouse work, then the team from Düsseldorf, Diran Hiribian, Annette Seibt, and Juliane Münch, the team from Jena, Melanie Roman and Ralf Husein, Sander Smits from our bioinformatics department, and also the team from Stuttgart, so Thomas Stralek and Professor Rafat. Thanks a lot for your attention.
So thank you very much for this very impressive results, in my opinion. So are there any questions?
Thank you so much. It's really, really impressive indeed. Did you ever consider treating the mother, so before the birth of the child?
I mean, based on the mouse model, you would think that this could be the next step. I mean, when you think of the oligohydramnios that the child had already prenatally, and there are also reports on, for example, prenatal brain anomalies in CoQ2 deficiency, that could be an option, yeah.
That's the longest way.
But it's so worth it. Fantastic presentation. Question: the other CoQ deficiency diseases, would they benefit? I guess no. But are there learnings from this that maybe similar substances could also have?
Yeah, I can give you an overview on that. It's there, okay, perfect. By the time I created an overview of the different CoQ2 deficiencies, so to answer your question, so 4-hydroxybenzoic acid would not work in the majority of other CoQ deficiency disorders. The only exception is HPDL, which was already presented here, so there are also indications that this could work. And in HPDL, the situation is that it is producing more or less 4-hydroxybenzoic acid. It's not the only enzyme which provides 4-hydroxybenzoic acid, but that's the mechanism behind HPDL, and here it's the transport. So therefore, for these two disorders, we have relatively clear ideas about the effect. For other disorders, so for the CoQ9 defect, we already had discussion. So we have in vitro and also mouse data that vanillic acid could at least improve the phenotype. So that would be interesting to treat CoQ9 patients with vanillic acid, especially because vanillic acid also has a food-grade label and should be well tolerated. It's also not a drug, as it's a bit comparable to 4-hydroxybenzoic acid, but it should be no major problem to give that to patients. And for vanillic acid in CoQ9 deficiency, this is more like a metabolic bypass. So this is a substance that carries a modification that is usually done by CoQ7 together with CoQ9. So if we shuttle this metabolite in the pathway, we can bypass this metabolic block and therefore increase the endogenous biosynthesis. And the in vitro effects are at least significant, but they are not as clear as for 4-hydroxybenzoic acid in CoQ2 deficiency. But the mouse model has a surprisingly good response to this vanillic acid treatment. So that's the next thing. And then there is 2,4-dihydroxybenzoic acid, which could be an option for CoQ7. But this is a bit more difficult to give because that could also have toxic properties. So that's not such an easy substance to try in a named patient use.
Thanks so much.
Any other questions? So again, thank you very much.
Thank you.
And I think we move on with the ceremony award, and I will turn over the mic to Ludger Schölz.
Stefan, it's a great pleasure and honor to finalize here this wonderful meeting, to have this last and most important session, the ceremony award. And we start with the Strümpel Prize. Gerald Fischer will introduce it.
Yes, it's the fifth time now that it's my pleasure to award the Strümpel Prize to a Best Paper Award for Early Career Scientists this year to Giulia Guarato from Italy. It's always getting closer and closer every year, and this year it was 3 submissions being very close. 2 submissions even had identical number of points, and for making it short, we were discussing it internally in the board of Euro HSP. very long. And what we liked is that your work has at the center a small molecule, a natural molecule with a very low risk profile. And to our opinion, this makes it worse that people are looking on it and further study it and try to bring it into application. And that was the reason for our decision. And for keeping it short, I ask you first to present your work. And if this goes well, you get the certificate, okay?
Well, okay, let's wait. Okay, I have to get it right then, okay. So, thank you for your kind introduction. Thank you so much for selecting our work for this prize. And I'm honestly really excited to be able to share this result in this kind of setting. So what we did in this work was to generate and characterize preclinical models that mimic the phenotypes in SPG 11 and 15 to then test and screen drugs that could actually be valid therapeutic strategies. So, nope. Of course, it's not working. It's fine. So SPG 11 and 15 have been discussed during these 2 days, so I'm not going to give you any more information about these two HSP forms. I'm just going to give you a couple of informations about the function of the two proteins mutated. So it's the SPG 11 and 15 are caused by mutations of spataxin and spasticin respectively, and these two proteins cooperate together on an endolysosomal level. Most importantly, they cooperate on the autolysosome membrane, and there they mediate the initiation of the autophagic lysosome reformation. This is a process of lysosome biogenesis after the autophagic cargo has been degraded. And during this process, tubular structures extrude from autolysosomes to form new protolysosomes that then mature into functional lysosomes. And mutations on either one of these proteins cause the block of this process, the reduction of the pool of functional lysosomes, and then a series of consequences, like the accumulation of autophagosomes and undegraded proteins. So what we did, we had So we had a cohort of SPG 11 and 15 patients in our center at the IRCS Eugenio Medei Institute, and what we did was to analyze these phenotypes in patient cells. Here, one of the first things that we noticed was a clear enlargement of lysosomes, an increase of their diameter, which in literature it's normally linked with loss of function or impairment of lysosomal function. And I would like to go on with this, but it doesn't matter. And one of the other things that we looked on was the accumulation of lipid species in lysosomes. Here we specifically looked at the accumulation of GD2 gangliosides in lysosomes, which had already been reported in other papers from other groups, which further confirms the loss of lysosomal function, and also, lastly, the accumulation of undegraded autophagosomes in both cell lines. Next, we developed and characterized two new Drosophila models, one for SPG 11 and 15, where the proteins are absent. And here we did kind of the same things we did in cells. So we looked at the lysosome morphology in larval muscles. As you can see here from the images, the size is markedly increased, but we also saw defects in the ALR process, in this case in vivo, where the tubulations lysosomal tubulations are present in control larvae, but absent in the two pathogenic models. And the loss of lysosomal function, of course, is connected to the accumulation of autophagosomes, not only in muscle cells, but especially in the central nervous system, especially with accumulation of undegraded proteins in the ventral nerve cord. So after we generated, characterized all these preclinical models, we wanted to test drugs. And we already had some information on some molecules that could actually work. We already published a paper on SPG15 models where we identified these small molecules, MER28, able to rescue the ALR process in vivo and then rescue all the phenotypes of these models. Although MER28 is not clinical trial ready, we have very few information about its pharmacokinetics and pharmacodynamics. So what we did was to look for other molecules that could have a beneficial effect on lysosomes, but were already in clinical trials. The first one is tideglusib, which can activate the TFAB nuclear translocation and then activate the transcription of genes involved in lysosome biogenesis and function. Next is naringenin, which can also activate the TFAB, but can also modulate ion channels present on the lysosomal membrane. And lastly, we tested miglustat, which is a glucosylceramide synthase inhibitor. This is an enzyme which is involved in the synthesis of gangliosides and lipid species, and it had already been tested in a clinical trial with 12 patients of SPG11, although it yielded negative results or no results. So we tested it in our models, especially to validate the pharmacological predictiveness of the Drosophila models. So starting on the data from cells, here we analyzed the effect of the 4 compounds on the lysosomal enlargement. And here, what we observed was that SMER28 and naringenin rescued 2 control levels, the lysosomal diameter. Tideglusib here was mildly effective and miglustat had no effect. And the effectiveness of naringenin and SMER28 was also replicated in the accumulation of GD2 gangliosides. Here, as you can see, the reduction of the accumulation, which was also given by miglustat. And I remind you, this is the specific mechanism of miglustat. So naringenin and SMER28 had a similar effect, total effect on lysosome accumulation compared to miglustat, but miglustat was not sufficient to rescue the lysosomal defect. So probably this is not the correct mechanism to go through. And lastly, naringenin and SMER28 were also effective in the reduction of the accumulation of autophagosomes. So then we moved on to the in vivo data, and we repeated the same experiments. So we looked at lysosomal enlargement, and as seen in patient cells, naringenin and SMER28 were the most effective, tideglusib was not effective as the first 2, and miglustat was ineffective. Next, we moved on to the ALR process. And I didn't say this before, but it must be said, this is the first in vivo protocol to analyze the ALR process. So what we did was to starve larvae, control SPG11 and 15 larvae, and dissect them at different time points. And what we observed after 6 hours of starvation, the ALR was induced in control larvae, but lysosomal tubulations were not present in SPG11 and 15 larvae. So after chronic treatment with our 4 compounds, we already knew that in the SPG15 model we had the rescue with SMER28, but we were amazed to see that also naringenin could rescue this phenotype, while tideglusib and miglustat didn't, but we kind of expected it depending on their pharmacological mechanism. And the same kind of results were replicated in the SPG11 larvae. So again, naringenin and SMER28 rescued this phenotype. And their effectiveness on an intracellular level was translated in their effectiveness in the locomotor defects. These are usually hallmarks of these neurodegenerative disorders. And so what we did here was to evaluate the locomotor efficiency of SPG15 and 11 fruit flies, adult flies, at 5, 10, and 15 days of their adult life. And after 5 days, they the 4 compounds kind of had the same level of rescue, but at 10 days we started to see some differences, with SMER28 and naringenin able to maintain the long-term locomotor activity, and while tideglusib and miglustat started to be less effective or ineffective. So at this point, we had these 2 molecules which could rescue all the phenotypes that we observed. So we asked ourselves how they could act on these 2 disease types. So we had two hypotheses, actually. So they could act by activating the lysosome biogenesis ex novo or by the induction of the ALR process. So we investigated the first hypothesis, and we analyzed the transcription levels of genes regulated by TFAB in patient cells, and what we actually saw was already an increase of their level. And after naringenin treatment and SMART28 treatment, we didn't see any modifications of their levels. Possibly this is due to the fact that there are already very few functional lysosomes, and this is a compensatory mechanism. So we discarded this hypothesis and we moved on to the ALR induction. And normally, ALR is induced after prolonged starvation by the reactivation of mTOR. And what we did to analyze the ALR induction was to quantify the protein levels of mTOR substrates in fly larvae, control and SPG15. And what we actually saw was that compared to control, in SPG15 larvae, we didn't observe any differences, meaning that the ALR process, even in the absence of spasticin, is correctly induced. And of course, after naringenin and SMART28 treatment, we didn't have any differences. So there must be something else. And in all the experiments that we did, one of the things that we noticed at some point was that in control cells, in basal conditions, so the ALR could not be activated, we observed some lysosomal tubulations independently of the ALR process, but those were absent in SPG15 cells. And after treatment with our two compounds, we regained also in this case the lysosomal tubulations, meaning that these two molecules, these two small molecules, can actually induce lysosomal tubulations completely independently from the ALR process, and then rescue the phenotypes observed in SPG 11 and 15. So to briefly conclude, here in this work, we managed to establish preclinical models, especially the in vivo Drosophila model, which can actually be a screening platform, a preclinical screening platform for the identification of valid therapeutic compounds. And in this case, we managed to identify two molecules, the actually first two known molecules to act on lysosomal tubulation. And as I said before, SMART28 is not clinical trial ready, but that cannot be said for naringenin. This is a small molecule. We already have some clinical trials, and these two clinical trials in particular have already defined and evaluated its pharmacokinetic profile. It seems to be quite a safe compound for human treatment. There are no severe adverse effects, and it could actually be a short-term option for SPG 11 and 15. We are actually evaluating it also for other HSP forms with similar ALR defects, but we are still working on it. Lastly, to conclude, I want to thank all the people that worked in this project from the University of Padova, where I worked until a few months ago, and then at the IRCS Medea Institute, where I work now, in particular Dr. Chiara Vantaggiato, Dr. Maria Teresa Bassi, and Francesca Brivio. And lastly, I would like to remember my previous supervisor, Professor Jenny Orso, who is sadly no longer with us, but she was a pivotal part of this project. Thank you.
Okay, I think we do the evaluation just by applause, yeah? and then Gerald can hand over the prize. Yeah? Thank you very much for this very nice work, and here it is.
Maybe we can take a picture?
And while we fix this very nice moment, I can introduce the following. There's something new. You all know we have poster prizes here in the Tom Barlick Symposium, and Henry and Susanne for this year decided to go a new way to. Yeah. Daniel Susanne decided to go for a new way to present and hand over these prizes, and they told me just in the last after the last session, and I liked it very much because it's bringing us closer to the patients and makes clear where these prizes are coming from and for whom our work is. And with that, you take it here and there.
Yeah, it's there. Okay. So now we are coming to the very last part of this symposium, the awarding of the poster prizes. And we need therefore your full attention once again. The poster presentations and the evaluation by the audience have become a fixed feature of the meeting over the last years. But this year, as Ludger mentioned, is a little change, and that is why we are seeing these slides here on the screens. These three families, you will see three in total, play a certain role for the awardees. When I talk to families and people who are affected by HSP, they very often ask, what can we do? Is there anything that we can specifically do for your foundation or for the researchers? And we all know why we're here, of course. We want to improve the situation of the people with HSP. And we are very glad about your great work. But it's a fact that groundbreaking therapies and pathways to cure are still a part of the future. And you, dear poster presenters and awardees, are a part of this future too. You can be very proud of what you have reached so far. We are very proud about it. And coming back to the question of the families, what can we do, brought me to the idea to create something like a personal sponsorship, like a godfather or godmother in some way. And I presented this idea at the last annual meeting of the HSP self-support group. And I'm very glad that these three families showed their willingness to be your sponsors. And they want to support young researchers with money. Each of them donated 300 euros for the prize, but also with their statements and their thoughts about research of HSP. And the idea behind is to intensify the mutual visibility of the one who have the need on the one side and the others on the other side who can fulfill this. And I think now it's time to reveal the secret about the awardees.
Yes, we had 22 posters, and it was a really close race as always, and I'm very proud to present you now the three winners. We had three clear winners. The first one, and I please welcome them here on stage, is Federico de Farias from Porto Alegre, Brazil. Please come to us. Congratulations first. Congratulations. With his idea in the whole group, I think really about building a trial-ready national cohort for HSP in Brazil in the Global South. Thank you very, very much.
Thank you very much.
The second winner, and we heard her already today, is Clara Metzner. Clara Metzner, please come on stage. With the, we heard it already, the fibroblast-derived induced neurons in HPV4. And the third winner, she just said farewell to us, but we give her a great applause to Italy is Francesca Zardina, spastin level regulation and biomarker development in SPG4. She just left back to Rome, but please give her a big applause. Then we take a last picture together. So, it was a great meeting. I think a lot has been said. Stefan is coming up again. Do you want to say something?
So thank you very much, and congratulations to the awardees. So I will make some closing remarks, not so long. I haven't prepared any slides. So I think it was a fantastic meeting. So thank you all that you were here. I think we had fantastic talks about new techniques, new genetic techniques, long read sequencing. We had examples from other diseases where we can learn a lot from. So we spanned the bridge very long. We had patient-related outcomes, and as I said before, I think today we have never had so many topics and presentations about treatment options for rare diseases, and that was fantastic, and thank you for that. And I think it's very important, and to close with the idea of the Knappschaft again, the community, especially in so turbulent times like this, it's very important that we keep this spirit of the Knappschaft, of the community, and that we do networking, and that's our idea, that's your idea for the Tom Wahrlich Stiftung, and hopefully we will see us again next year, wherever it is. Okay, thank you very much for coming. That's it.